Are we
Okay.
live?
Yes.
Good morning. I am Dr. Brita Lundberg, an infectious disease specialist and internist and chair of the Mass Medical Society Committee on Environmental and Occupational Health and the board chair of Greater Boston Physicians for Social Responsibility. I would like to extend a warm welcome today on behalf of GBPSR and the Mass Medical Society, co-sponsors of today's event. Thank you for joining us today. I'd also like to thank my joint committee members from GBPSR and the Mass Medical Society's Committee on Environmental Occupational Health for their hard work on pulling together today's outstanding program. And a huge thanks also to GBPSR Executive Director Anna Baker. A huge thanks to our speakers for their time and dedication to increasing learning and understanding around air pollution, its health effects, and what we can do about them. A few items that I've been asked to mention before we begin. As a reminder, this event is being recorded. All individuals in control of the content for a CME accredited continuing education activity must disclose all financial relationships with ineligible companies. For this activity, individuals in control of content did not disclose any financial relationships with ineligible companies. If you have questions during the presentations, please type them in the comments setting on the YouTube page where you're watching. And please indicate if you would like to direct your question to a specific speaker. Please feel free to submit questions throughout the event, and we'll do our best to address all the questions after the presentations. I'll give a brief introduction to our topic today and then introduce our speakers. So slide 1. The epidemic of air pollution is more of a pandemic. According to a report released this week by the World Health Organization, man-made air pollution affects billions of people. 99% of us on the planet breathe poor quality air that does not meet WHO standards. This data in the slide from the National Oceanic and Atmospheric Administration and NOAA shows that fossil fuel emissions, and the red line is carbon monoxide and the blue line is methane, are increasing exponentially. A whopping 262% increase in methane emissions and 149% increase in carbon dioxide since pre-industrial times, with 12% of that steep increase in methane emissions occurring just in the past 2 decades. According to NOAA, production of both greenhouse gases hit a new record this week. Slide 2. Next slide. But it's not just methane and carbon dioxide that are released when oil, coal, and gas are burned, leaked, or extracted. There are the pollutants that might be called hitchhikers that travel with it. I have in the schematic at the top the criteria air pollutants, which have set standards, and they include carcinogens, respiratory irritants, neurotoxicants, or all three. The most notorious that folks might be familiar with are ozone, carbon monoxide, nitrogen dioxide, and particulate matter. All of them are bad actors. Methane is a key contributor to ground level ozone, known as smog. The photos at the bottom of the slide are of black carbon, soot, otherwise known as particulate matter. This is a natural gas pipeline that's being, quote, cleaned out or pigged out. And it offers a visual that helps explain where the particulate matter and pollution comes from when methane gas or coal are burned and result in air pollution. Slide 3. So our goal for today's webinar is to make clear the connection between our ever-increasing levels of air pollution, the health and especially equity and economic costs of that pollution, how it drives climate change, and what we as health professionals and community members can do about it. End of slides. Now, to introduce our speakers, Professor Faber, Woof, Dominici, and Clay, who will discuss the health, economic, and equity costs of air pollution.
Good morning, everybody. Thank you for being here. I'm Professor Daniel Faber. I'm Director of the Northeastern Environmental Justice Research Collaborative. I want to very quickly speak about what I see as a major paradox confronting the environmental health movement. And that is, on the one hand, over the last 40 years, environmental health activists have created one of the most advanced systems of regulation in the world. But on the other hand, it's proving grossly inadequate for protecting the health and well-being of the American people. And one of the hallmarks of standard environmental policy in its efforts to protect the general public, many times the ecological crisis is being displaced from one realm of nature to another. So, for example, if you can no longer dump toxic waste in the Charles River, which is a good thing, but if this toxic waste, which used to be dumped, is now collected in barrels and transported to other communities around the country where it's to be incinerated, then the problem hasn't been eradicated. It's just been displaced from one part of the country to another. And what we see over the last 30 years is that more and more of these ecological problems that are being captured are actually being displaced onto low-income communities and communities of color. Hence the rise of the environmental justice movement over the last 3 or 4 decades. And as we just saw, the ecological crisis is continuing to deepen, whether we're talking about climate change, air pollution, the chemicalization of our everyday environment. Centers for Disease Control have done these studies of babies showing that they are grossly pre-polluted in American society. And we know that air pollution kills. It kills many more than we originally thought. New research from Harvard University has found that it kills about over 8 million people each year globally, accounting for 1 in 5 deaths. About 355,000 people in the United States die prematurely from air pollution. So when we look at where is air pollution being distributed and who's being impacted to the greatest degree in the United States, we find that very often the state or polluting industries target their facilities to be located in communities that have less political economic power, that have less ability to resist the imposition of these facilities. If you look at California, for example, where they were adopting the use of incinerators to deal with trash and chemical waste and medical waste, residents throughout the state did not want to be located next to incinerators, and for good reason. They emit mercury and dioxins and other heavy metals. So the state of California commissioned Sorrell Associates to help them figure out where they should locate these incinerators. And on page 51 of their report, they conclude, under no such circumstances should such a facility be built within a 1-mile radius of a white middle-class community because of the greater likelihood of encountering political opposition. Instead, they should target rural communities, Catholic communities, which are considered to be more conservative, footnote, communities of color, and low-income communities. And so after the report was issued, you find that in Los Angeles, for example, where they built 17 incinerators, every single one of them was located in a low-income community of color. So if you look in a community like Lawrence, Massachusetts, the state decided to build 4 incinerators within a 12 square mile area of downtown Lawrence. And Lawrence at the time was one of the poorest communities in the state. Half the population did not speak English as their first language. They were deeply divided by ethnicity, nationality, point of origin. Country of origin. And so they were highly fragmented with what we call churning. There's a lot of turnover of the population. And that made them easily targeted for the location of 4 incinerators, each which was emitting 2,000 pounds of mercury each year into the environment. Recent studies have shown that the highest levels of mercury found in the environment in anywhere in the eastern United States are now in the Merrimack Valley, particularly around these incinerators. So this is often called environmental racism, and the manner in which low-income communities of color, Black, Brown, Indigenous, and even poor communities are the ones that are continually targeted because they lack the political economic power to resist. Some 80% of all the incinerators nationwide are located in communities of color. And as a result, for example, Black or African American populations have 1.5 times the exposure to particulate matter compared to the overall population. And study after study shows that there's an unequal health burden that is borne by people of color all over the country, including here in Massachusetts. I did a study, and this gives you an example of some of the disparities that we can see here. When I did the study, there were over 20,000 hazardous waste sites that were located in Massachusetts, and we were interested in where were these waste sites located. And you see on this chart, in predominantly white communities, there is an average of 2 hazardous waste sites per square mile. But in communities of color, there is an average of 48 hazardous waste sites per square mile. And you don't often see this in the social sciences, but it's a one-to-one correlation, meaning as a community becomes more racially diverse, there is a direct and corresponding increase in the frequency of hazardous waste sites in that community. In other words, race by far is the most powerful indicator of whether or not there's going to be toxic waste sites and how many in that community. And we see the same is true with regard to the income status. Low-income communities are also exposed disproportionately. Skip over New Bedford in the interest of time. And, there are a number of different indicators which are kind of interesting, including hazardous or dangerous polluting facilities. And what's kind of curious about this is that Massachusetts ranks as one of the worst states in the country in terms of socioeconomic status, living in proximity to some of the most dangerous industrial facilities in the country. So we have the highest number of people living in poverty next to these facilities, as well as elderly populations. And as we know, in case of Danvers, living next to these facilities can be quite dangerous. So we were interested in looking at of the distribution of pollution that takes place in communities into the air, as well as the water and the ground. And this is a very interesting graph. What it shows that over a 10-year period where we were crunching these numbers, over 19,000 pounds of toxic chemicals were released into the air, the ground, the water in predominantly white communities, 19,000 pounds per square mile. But look what happens when you get to larger communities of color. It's almost 200,000 pounds of toxic chemicals released into the air, water, and ground in communities of color. And when you break this down and look at the distribution of carcinogens or mutagens or chemicals that cause birth defects, you find that the worst types of pollutants are overwhelmingly or disproportionately released into communities of color in Massachusetts. So, for example, even though communities of color only made up 9% of all the communities in the state, they receive over 40% of the carcinogens that are released by industry into the environment. And again, you can see that class matters quite a bit. Low-income communities also have much higher levels of pollution. Traditionally, living next to a power plant could take months, if not years, off your life expectancy. And 68% of African Americans nationwide live with 30 miles of a coal-fired power plant, which is the high impact zone. And traditionally in Massachusetts, over the past 3 decades, we saw that 4 of the 6 worst polluting power plants in Massachusetts were located in low-income communities. So as a result, the number of these different studies, University of Minnesota has found that on average, people of color are exposed to about 38% higher levels of pollution. Running out of time here, and this is what's interesting, we're a blue state, but some of the greatest racial disparities that exist in the nation with respect to air pollution are actually here in the Northeast. And you see that Boston ranks 4th in the country. The cumulative environmental burden for communities of color is over 25 times greater than what it is for predominantly white communities. And as you can see on our list, if you live in a community of color, there are 362 communities in the state, you are almost guaranteed to live in one of the most polluted communities in the entire state. So the last thing I would say here is that the goal of the environmental justice movement is not to ensure that all people are polluted equally. It makes for a terrible bumper sticker. It's not a great slogan. the real focus of environmental justice politics moving forward with regard to environmental health is to ensure that no one is polluted at all. In other words, not ensuring the equitable distribution of environmental harm, but beginning to introduce a more transformative environmental justice politics that would address the root causes of the ecological crisis so that no one is exposed to environmental harm. And I look forward to discussing this a little bit further down the line in our discussion period. So thank you very much.
Thank you so much, Dr. Faber. Now we will have Professor Jennifer Woovey, who's an associate professor of epidemiology at the Boston University School of Public Health. She's the PI or co-investigator on several epidemiologic NIH-funded studies of air pollution and dementia. Dr. Woovey.
Thank you. I assume that you can see my slides. Is that correct? All right, I'm going to proceed. So thank you for the invitation to speak to the PSR audience. There has been a rapid proliferation in research on the influence of air pollution in the development of dementia. And my goal is to explain why air pollution could play such a role and what the accumulated evidence suggests. But first, my disclosures. So when we speak of air pollution, we are referring to contaminants in the air from processes that involve either burning or grinding. And for this talk, I will be focusing on pollutants in outdoor air. Now, some examples of those burning processes are fuel combustion and forest fires. And examples of grinding processes include vehicular braking and the friction of tires over roads. Now, the air pollutants that we are exposed to may come from local sources, as we just heard, such as road traffic, and that road traffic could just be a couple blocks away, or as experienced by folks in the northeastern US, whose air was polluted by coal burning in Pennsylvania. Pollutants can travel from hundreds of miles away. Now, the source of the air pollution determines its composition. And among the most common pollutants generated, as you've heard about, are oxides of nitrogen, a range of carbon compounds, and particulate matter. Now, these are called primary pollutants. And after some of these pollutants undergo transformation in the atmosphere, secondary pollutants are formed. And among the most familiar to you is probably ground level ozone. Now, that particulate matter I mentioned is extremely common and consists of bits of solid and liquid suspended in the air. And these bits might include carbon, metals, embedded gases, or a mixture of components. And composition not only tells us about the source of the particles, but may portend their toxicity. Now, the size of the particles matters as well, and the general rule being that the smaller the particle, the more deeply it can penetrate into the body. And we can use this ruler of tiny things to get a sense of the sizes of particles in the air pollution lexicon. So let's use some examples. So particles that are 10 microns in aerodynamic diameter or smaller are capable of being inhaled beyond the larynx, and thus we call them thoracic particles. We also call them PM10. Now, within PM10, the coarse or the larger fraction consists of particles with diameters as small as 2.5 microns. And then the smaller particles are called fine particles, or PM2.5. Now, I'm going to switch gears for a second because you also heard me mention dementia in the title. Now, let's address what we even mean by dementia. Dementia is a syndrome, and it's characterized by deficits in cognitive abilities, importantly, memory, from some previously higher level. And the extent of that deficit is such that it affects a person's ability to perform everyday activities for independent living. Now, we can think of cognitive function as lying on a continuum, and dementia representing decline to a low level of cognitive function. Now, as you probably heard, because of the aging of the population, and because age is such a strong predictor of dementia, the prevalence of Alzheimer's disease dementia is expected to triple by 2050 compared with its prevalence in about 2000. Now, I want to point out, though, that dementia is not a so-called normal part of aging. Certainly, the risk of dementia increases dramatically with age, and this has been documented in a number of studies. This increase in risk is approximately exponential. And dementia is also common as well. Among the oldest adults, people who are 85 and older, perhaps 1/3 of people have dementia. But the flip side is that 2 of 3 older Americans do not develop dementia before they die, and I think that's really important to consider. I also want to point out something that we are thinking about, especially when we think about air pollution and dementia. Alzheimer's pathology is very common in people who have dementia, and yet when we look at the brains of people after they die, who have been diagnosed with Alzheimer's disease prior to dying, most of these cases include Alzheimer's pathologies, amyloid plaques, tau tangles, but they also include other pathologies such as vascular pathologies, Lewy bodies, and so on. And you can see here very few people in this study who had Alzheimer's dementia prior to dying had only Alzheimer's pathologies. Now, why does this matter? Well, first of all, I want to point out that no drug has been shown to alter the clinical course of Alzheimer's dementia, even though many have been tried. And this even pertains to the most recently FDA-approved drug, an anti-amyloid agent, which really successfully reduces amyloid in the brain, but does not markedly stall cognitive decline. But air pollution is a little different. And so how might air pollution influence development and progression of dementia? Well, first, exposure to some air pollutants, even at subregulatory levels, appears to have adverse effects on cardiovascular disease. And given the known dementia risks that follow heart disease, it could be that air pollution affects dementia risk without even invading the brain. So, forgot that there. But animal and autopsy studies suggest that some pollutants do make it to the brain, possibly through circulation or an olfactory route. And how they get there, if at all, air pollutants may act pleiotropically, having been linked to myriad dementia-relevant processes and pathologies, not just amyloid and tau. And I want to also point out that in addition to air pollution potentially acting on multiple channels relevant to dementia, it is worth noting that in the United States, exposure to clean air, as we have heard, is not distributed equitably. For example, persons from non-Hispanic Black communities are more likely than non-Hispanic white persons to live in areas with higher concentrations of NO2, PM2.5, you name it. And as you can see in this graph here, and this inequity in exposure could be yet one more way that racialized communities bear additional dementia risk. Now, animal and autopsy studies are one thing, but what do we see in epidemiologic studies of humans? And this is what my colleagues and I set out to evaluate, as reported in our recent paper. So this, just to get you oriented, this picture shows the cognitive trajectories over the lifetime of 4 hypothetical people from birth to death. And so here's cognitive function on the y-axis. And I'm showing this to you to illustrate the major outcomes that our review encompassed. So first, for studies of cognitive functioning at any given age. So we compare cognitive function across levels of exposure to air pollution. There were also studies that compared rates at which individuals' cognitive abilities declined. And then there were studies of incident dementia and impairment. And as you can see, and as many of you know, dementia is a function of where you are now and how much you have been declining. I also want to mention that we looked at studies of brain imaging as well. Most of those were structural imaging studies. Now, what we identified was 66 studies, and there have been more since then. And so quite a bit of literature, 25 on cognitive level, 9 on cognitive decline, 22 on incident dementia, and finally 15 on brain imaging. And of the pollutants investigated, the most common were PM2.5 and NO2, or oxides of nitrogen. And this is partially a function of taking advantage of what we already monitor from a regulatory perspective. There were fewer studies on, say, ozone and the coarse fraction of PM. The studies took place in North America, Europe, and Asia. And unfortunately, there have been no studies conducted elsewhere. We summarized this evidence by restricting the papers to the 35 studies that we deemed to have strengths with respect to 5 sort of methodologic features. And I'm not going to detail those here, but the overall idea was, let's summarize findings from the highest quality studies. And here's what we found. The evidence was most consistent for PM2.5. And those findings pointed to an adverse effect, but mostly for cognitive decline, and less consistently for cognitive level and brain volumes, although there were some suggestive findings. The findings on dementia in this subset of papers were pretty sparse and somewhat consistent with an adverse effect, but pretty too sparse to really cast a judgment with confidence. Now, by contrast, findings from papers on PM10, oxides of nitrogen, and other traffic-related air pollution measures were mixed, and findings on ozone and coarse fraction PM were too sparse to conclude much at all. So, just because some of these findings were mixed or sparse doesn't mean that there isn't something to be discovered and that there isn't something there. And we actually have some recommendations for where the research should go in the future. And a lot of that considers how we assess people with dementia. And a lot of studies relied on the medical system to identify people. And a medical diagnosis is, at least as we find on Medicare claims or medical records, has a positive predictive value of about 50%. So this is not terrific, especially considering the drivers of diagnosis itself, not having dementia, but getting diagnosed. And we have several other recommendations to give as well, and I'm not going to go into detail on those for lack of time here, but I do want to conclude by acknowledging my colleagues in this research and then turn it over to the next speaker, who I believe is Francesca Dominici, Professor of Biostatistics at the Chan Harvard School of Public Health.
Good afternoon. Thank you very much for inviting me. And it will be my pleasure to present some of our research on the link between exposure to air pollution and COVID-19, really emphasizing the importance of data science. I am a professor of biostatistics, population health, and data science at the Harvard Chan School of Public Health, and also co-director of the Harvard Data Science Initiative. When we began with the first wave of the coronavirus pandemic, having worked for many years on adverse health effect of air pollution, the first question that came to mind was, is air pollution and exposure to air pollution making the coronavirus pandemic even more deadly? So with my colleague at the Harvard Chan School of Public Health, we conducted the first ever study providing evidence of a link between exposure to air pollution and the COVID-19. And this is the press release, well, the article from The Guardian covering the results of our study. How the idea came from? Well, one of the reasons why I started to think about this issue is with my colleague David Christiani, who is a professor also at the Harvard THN School of Public Health. We both co-advised a former PhD student, Jong-Eun Ri, few years ago, way before the pandemic, where we provided evidence that there is a relationship between long-term exposure to air pollution and acute respiratory distress syndrome. And as many of you know, one of the main causes of deaths for the first wave of the pandemic for COVID-19 was indeed acute respiratory distress syndrome. And that was really, in addition of everything I know about the health effect of air pollution, if air pollution may increase the risk of acute respiratory distress syndrome, and if acute respiratory distress syndrome is a main cause of death for COVID-19, clearly there could be a linkage between long-term exposure to air pollution and COVID-19 deaths. So we published this important study now back in November 2020, which was the first nationwide study where at the county level, we linked long-term exposure to fine particulate matter to COVID-19 deaths for all of the main counties in the United States. By the way, this was published in the journal Science Advance. And what's important also to point it out that we made all of the data and the research code and the statistical code publicly available, so you can download and actually look at it. So what did we do? Well, we had many years of experience in using machine learning models and artificial intelligence model to estimate exposure to fine particulate matter 1 kilometer, 1 kilometer grid, and therefore for any county in the United States for the last 20 years. And that's the map on top shows the ambient level of fine particulate matter in the United States on average during the period 2000-2016. The map on bottom was for the first wave of the pandemic, which was March to June 2020, the total number of COVID-19 deaths by county. So we built a statistical model to look at the relationship between county level exposure to fine particulate matter and county level exposure to, a county level number of deaths for COVID-19. Clearly, when you are trying to look at the relationship between these two variables, you need to consider many other county level covariates that could potentially confound the relationship. So in addition to COVID-19 deaths cases and COVID-19 deaths and cases, in addition to fine particulate matter, we gathered a lot of information on number of hospital beds, population density, the age structure, demographic, education, income, behavioral variable, and so on. So we built a regression model where we show that what we found that only 1 unit increase of long-term exposure to fine particulate matter were associated with an 11% increase in COVID-19 mortality rate. And so another way to think about it through a regression model is that if you take two counties that are very similar to each other with respect to a lot of information, population density, socioeconomic variable, access to healthcare, the county that had been higher level of fine particulate matter had an 11% mortality rate for COVID-19. This plot on the bottom shows the estimates of the mortality rate ratio as the number of deaths kept accumulating over time, and you can see that actually the estimates that it's now in this plot around 8% tends to be pretty stable over time. Now, one of the major limitation of the study, which we were very aware at that time, was that this is called an ecological regression analysis, because we regress county level exposure data on county level mortality data, and therefore you cannot make conclusion about individual level association. Now, since then, we have a second research study that is under peer reviewed, where we augmented this information with a national representative sample in the United States with individual level data on demographic and socioeconomic status. And we found that still there is a statistically significant relationship between long-term exposure to fine particulate matter and COVID-19, even when we adjust for ecological bias. So this is the coverage that the study had in the New York Times, and the study was, the two co-lead author was Zhao Wu, which was a former PhD student in my lab, and Rachel Nethery, which is an assistant professor in the Department of Biostatistics. The other really important results, which unfortunately is very well known, is that counties that have higher percentage of Black residents have a much higher rate of COVID-19 mortality. We found that for 14% increase in the percentage of Black residents, we have a 49% increase in COVID-19 mortality. Also with another colleague, Tanuji Day, is a faculty member in the Brigham Women, we further characterize the clinical, environmental, and racial the determinant of COVID-19 on this commentary, on this short review paper, and really pointing out that exposure to air pollution, but also underrepresented minority socioeconomic status and the presence of comorbidity could further exacerbate and increase the risk for COVID-19. Another really important aspect of our work was to establish a connection and report a connection between exposure to wildfire smoke and COVID-19 cases and deaths. So last summer, as we all know, we had a tremendous situation where, also last summer, but even more in 2020, before we had the vaccination for COVID-19. So in summer 2020, we had two catastrophic events happening at the same time. One, we were having the COVID-19 epidemics, plus we were having, especially in the west part of the United States, these very extreme wildfire days. So what we wanted to do is also look at the relationship between exposure to wildfires in the United States and excess of COVID-19 cases and deaths. So we conducted a second study, also published in the Journal of Science Advance. Again, the data and code is publicly available. And what we did, we got data on the daily number of fine particulate matter attributable to wildfire smoke, together with daily number of cases for COVID and deaths for COVID for over 92 counties in the United States. So this was work with Jadon Zhu, which is a data scientist at ESRI, Environmental Science Research Institute, and Kevin Josie, a postdoctoral fellow in my lab. So we gathered publicly available data on daily observed level of fine particulate matter. We gathered data from NOAA hazard mapping system to look at daily smoke density. We had information at county level of daily number of cases and deaths, daily information on temperature, and daily information on county population, traffic values, and mobility, and many other important information. So this is a map that this plot shows you, for example, if you focus on the plot on the left, on the on the high left, that is a daily time series for Los Angeles County. So this blue dot shows the daily number of fine particulate matter. So they vary between 5 microgram and 60 microgram, and the orange bar are the level of fine particulate matter they are occurring during the wildfire smoke days. So you can see that from the satellite, we know when is a day that a wildfire is occurring, and you see that this level of fine particulate matter really peaked very high. The red dots are daily number of COVID-19 cases, and the blue dots are daily number of COVID-19 deaths. And so you see that we have all of this information for the 92 largest counties in the western part of the United States. It was really important to estimate the daily number of fine particulate matter that were directly attributable to a wildfire day. And the way we did that is basically we took the blue dots were the daily number of the daily levels of fine particulate matter during the summer 2020. Then the dark line represents the historical level of fine particulate matter for the same county for the same day by average the years before and on years where we did not have wildfires. And so the difference between the blue dot, which was the observed PM2.5 level on a wildfire day, and the dark dot, which is the historical level of PM2.5, give us an estimate of the higher level of fine particulate matter that were attributable to these wildfire days. And so the orange line really show you how much more PM2.5 attributed to wildfire we got to be exposed to during these wildfire days. So what we did, we built a pretty rich statistical model to try to assess the percentage increase in COVID-19 mortality or the percentage increase in COVID-19 cases by county that were attributable for any 10 units increase in fine particulate matter. So the plot on the left shows the relative risk for the COVID-19 cases. For the plot on the right was for COVID-19 deaths. And you see that there is a quite significant heterogeneity in the relationship between exposure to PM2.5 from wildfire and COVID-19 cases and deaths. For the majority, these relative risks are positive, so exposure to fine particulate matter is harmful to COVID-19 cases and deaths. But we did see that for some counties is, although not statistically significant, was protective. But for some county, for example, if you look at the county on the bottom, you see that for Whitman County in Washington, Sonoma County in California, we have the 10-unit increase of fine particulate matter for several consecutive days were associated with up to a 60% increase in COVID-19 cases. So this work had also an enormous amount of press coverage because not only we knew that we documented the long-term exposure to fine particulate matter was leading to a higher percentage of higher risk of mortality, but also short-term increase of very high level of fine particulate matter during the wildfire days. It would make COVID-19 much worse. We provided, you would see in the paper, infographic where you can click, and this was a collaboration with Esri. This is a plot that, for example, shows what's happening in Fresno. In Fresno County, we click on the county of Fresno, for example. In the county of Fresno, we have 81 days where you have wildfires during the summer 2020. Here you see the level of PM2.5. The yellow are the ambient level. The orange are the level attributable to wildfires. The bottom is the daily number of COVID-19 cases. So we estimate that the level of PM2.5 on average was 30 micrograms per cubic meter on wildfire days, and it was 6 on the no-wildfire days. And we had a 1,628 extra COVID-19 cases that are attributable to the level of PM2.5 during the wildfire days and 131 deaths. And finally, I think I wanted to mention a global study that we conducted with our colleagues from all around the world, where we tried to estimate the percentage of the total number of percentage of the total number of COVID-19 mortality that is attributable to fossil fuel related emission and all the anthropogenic emission. And so we found, for example, that in North America, 14% of all of the COVID-19 mortality is attributable to fossil fuel related emission and 17% to all anthropogenic emission. Not surprising, for example, we had much larger number in East Asia with 15% attributable to fossil fuel and 27% attributable to all of the anthropogenic emission. So to conclude, we do believe that the power of data and the importance that, looking ahead in terms of understanding the critical risk factor of influenza and COVID-19 and other diseases is really important to develop a new research data platform that can link data on meteorology, climate, air pollution, land use, using sensor readings to really understand the linkage, quantify linkage with the health indicator. And also, though I didn't have much chance to talk about here, is really to understand the distribution of this adverse health effect in disadvantaged population. Thank you very much for your attention.
Thank you so much, Dr. Dominici. I would now like to introduce Professor Karen Clay, who's Professor of Economics and Public Policy at Carnegie Mellon, the Tepper School of Business, and the Department of Engineering and Public Policy. She's Research Associate at the Cambridge-based National Bureau of Economic Research. Karen, thank you.
Thank you to everyone for having me, and thank you for to the previous person who, Francesca, did a great job touching on a lot of important issues. Okay, so I am an economist, and I'm going to talk a little bit about the economic impacts of air pollution. The first question you might have is sort of, why do economists care about air pollution? So we'll talk about different dimensions along which economists have looked at air pollution. We'll talk a little bit about regulation and specifically the Clean Air Act of 1990, and then talk a bit about the aggregate impacts in terms of economics of air pollution. Okay, so economists look at air pollution through lots of different lenses, depending on the specific questions that they're interested in. There's a large literature on the effect of air pollution on children and their ability to build human capital, which you should think of as schooling and other skills that will serve them well in adulthood, and as well as some work on health impacts of children, on children. For adults, there's been a lot of work on productivity, and we'll get back to that when we think about firms and health impacts. And then for the elderly, because they're typically out of the workforce, much of the work has focused on the health impacts. And so there's been really important work on all of these issues, and of course, especially the health impact, important work being done by epidemiologists, important work being done by economists. In terms of animals, there's much smaller literature, but still interest in animals, both because of their importance in production, so animals that we eat, but also wild animals and the impacts of air pollution on pets. In terms of ecological impacts, there's been a lot of work on the importance of or impact of air pollution on agriculture and timber, because those are also big economic factors and, of course, impact more broadly on ecosystems. Economists, when they turn to look through sort of the lens that focuses on firms, are more focused on worker productivity, because there are some very important studies showing that workers are less productive if there's high levels of air pollution. And firms are, of course, in some cases also exposed to the health costs associated with that. Firms have expenditures to mitigate air pollution, which can be significant, as you'll see when we get to talking about the 1990 Clean Air Act. And then there are financial impacts on firms from good or bad environmental actions. And so there have been a sets of studies looking at things like stock market impacts from revelation of important information. Economists also look at the importance of air pollution for housing. And the reason is because the price of houses is impacted by many factors, and one of these factors is actually air pollution. And so they look at both cross-sectional variation, so variation comparing a house in one location with a house in a different location that has slightly different levels of air pollution, but also basically significant declines in air pollution that vary across space and allow you to estimate, again, the effects of air pollution on housing. And finally, economists have looked at travel, and travel's certainly another important economic factor. And one wants to typically go to places that have nice blue skies. And so Air pollution is generally not a positive attribute when thinking about traveling. And there's been a fair amount of work specifically on national parks and air pollution impacting visibility in national parks. In terms of government expenditures, which is something we haven't talked about so far, economists, of course, are interested in this as well. Governments, both at the federal, state, and local level, are involved in regulation and monitoring. This costs money. It's also the case air pollution has impacts on government programs such as Medicaid and Medicare, which pay some of the health costs of air pollution, as well as Social Security, and then impacts of costs of air pollution on costs of borrowing, particularly at the municipal level. Okay, so turning to the idea was really just to give you a sense that economists care about air pollution in lots of dimensions. And now I want to turn and talk a little bit specifically about regulatory settings because they're incredibly important. Almost all regulatory work has to provide RIA, which compares the costs and benefits of a regulation. Benefits usually focus on decreases in mortality, and you might wonder why. It's both because deaths from air pollution are measurable, and we have a very long and well-established literature that actually looks at the dose-response function. And so that's quite well understood. The other part of this is that deaths are highly valued. So we use value of a statistical life, which basically represents small trade-offs in terms of money and risk. And the value of a statistical life that's currently used by government agencies is about $10 million. And so this is assigned to premature deaths from at all ages currently. Economists, of course, recognize that there are many other benefits to reducing air pollution, but when deaths are both measurable and highly valued, they tend to be a dominant part of the cost-benefit analysis. So to see this, I like to talk about the Clean Air Act because there's this lovely analysis of it. And it tells us a few things that are really important in terms of thinking about regulation. First, the Clean Air Act of 1990 was very expensive. You can see that there are billions of dollars being spent in terms of compliance by industry, by localities, and to meet national standards. The good news is that it reduced emissions, and so it reduced volatile organic compounds, nitrogen oxides, sulfur dioxide, and fine particulates. These are all precursors or direct contributors to PM and ozone, which are things that we care a lot about. And this gives you a sense of the costs and the benefits. So you can see that, yes, there were significant costs, but they are dwarfed by the benefits. The benefits are primarily coming from mortality. As I talked about, we have dose response functions and high valuation of premature death, and those combined give you very large numbers in the mortality category. We also care a lot about morbidity, so things like bronchitis, heart attacks, asthma attacks, emergency room visits. You'll notice that the morbidity alone, even if you ignore the mortality, is about the same order of magnitude as the direct costs. So we're getting benefits, significant benefits from morbidity, visibility benefits, both in the residential category, so being capitalized into housing, and in terms of travel. So again, morbidity and visibility are both in their own right significant. We also have other monetized benefits, and then of course there are lots of things that are hard to monetize, and so are represented here by the question mark. The last thing I want to talk about are the economic impacts of air pollution at the aggregate level, because it's sort of hard, I think, sometimes. You can look at these numbers and think, well, okay, how should I understand what's happening today? And so I want to talk about some important work by my colleague, Nick Muller. And he goes back to the 1960s and 70s and finds that environmental damages attributable to air pollution alone were 32% of GDP. That is just an enormous number. He finds that it falls as a result of the regulations, the kinds of regulations that we've talked about, such that by the 2000s and 2010s, they had fallen to 10% and 8% of GDP. So still big numbers. And just to give you a kind of more concrete sense of this, in 2019, which is the pre-COVID year, GDP was about $21 trillion. So 8% would be 1.7 trillion. And even if you think that the number has fallen a bit, we're still over $1 billion a year in terms of air pollution and environmental damages. So really big numbers. And so hopefully this is sort of giving you some insight into some of the economic impacts of air pollution. So that's it. Please follow up if you have questions. My email is on the slide. Thank you.
Thank you so much, Dr. Clay, for that excellent presentation. We will now move to the question and answer portion of today's program, of this panel section. As a reminder to our audience, if you have questions, please type your questions and include who you would like to answer them, if there is someone you'd like to direct them at, into the comment box. To begin, we'll address a few questions that we received in advance, if we can bring up our speakers. Given, I think this is probably addressed to Danny Faber, Professor Faber, given some of our other conversations today about equity and environmental justice, are certain subgroups of the population more burdened by the costs of improving air quality? And do certain subgroups benefit more from legislation like the Clean Air Act?
Yeah, I think what's interesting in a lot of the research shows that a lot of communities where there's a turnover, or what we call churning, where there's a lot of new immigrant populations coming in, that they're experiencing actually higher exposure to ecological hazards than more well-established, long-term, and homogeneous communities of color. And so that sort of points to the fact that the ethnic and racial and class divides that exist within many of the new immigrant communities are preventing the residents from coming together and speaking with one voice and resist the imposition of, ecological harm. So I've been testifying in cases, for example, in Brockton, where there's an attempt to build a power plant near an elementary school. As an example, in Brockton has a high percentage of an immigrant population that's relatively new. So taking the lens of political economic power and the ability of communities to mobilize themselves is really such an important determinant on whether or not a polluting industrial facility or a toxic waste site gets located within that community. And very, very quickly, the one other thing that I would mention, it's kind of a contradiction that many in environmental justice and environmental health advocates are facing now, is that in communities like Roxbury and others in Boston, where there have been struggles on behalf of the residents to clean up their communities and make them more livable, they've been really quite successful over the years. But the downside of that is that it's resulting in higher property values and increased rents and taxes, and that is resulting in an economic displacement of many of the very same residents who led these initiatives. And we've been trying to track where many of these residents, if they become displaced economically after their communities have been cleaned up, and we're finding that they're relocating back to more polluted communities because the property values and housing is more affordable, like Brockton and elsewhere.
Thank you for that, Danny. That's just perfect. Thank you. Professor Clay, I have a question for you. So the NBER showed a steep increase in PM 2.5 in its, I think it was a 2018 study, that correlated with decreased enforcement of the Clean Air Act. Has enforcement changed at all in the last 2 years? And has PM 2.5 improved at all with the change in political administration?
So yes, it looks like we've done a little bit of work to try and update our study, and have found that it does look like it's starting to improve again. All of these things take a little while to get going, and so it does also look like we're seeing more aggressive EPA enforcement, but it takes a little bit of time.
Right. Excellent. Good to know. Thank you. And for Professor Dominici, I have a question for you. So you had some excellent studies correlating PM 2.5 with COVID-19 mortality. And a recent study came out of the Harvard Chan School of Public Health showing that carbon monoxide mortality, for every degree of increased carbon monoxide exposure, mortality increases. Have there been, and I know that PM 2.5 is sort of considered a surrogate marker, if you will, for carbon monoxide, but have there actually been studies looking at CO exposure and mortality from COVID-19?
Good question. There have been an explosion of epidemiological study relating exposure to air pollution and the COVID-19 mortality in cases, both in the United States and around the world. So to my knowledge, I haven't seen a national-wide study on CO2 and COVID-19 mortality for the United States. It's definitely something that we can do. So among our plan to extend our study, we are planning to look at CO2 as well. So to my knowledge, I haven't seen it, but I might be wrong because the literature is rapidly
Exploding.
Exactly. And so there might be a study coming up tomorrow.
I was just interested. Thank you so much. Professor Woovi, I have a question for you. So there has been some literature recently, actually I also think out of either the Broad Institute or the Harvard School of Public Health, about the effect of NSAIDs on cognitive decline and after exposure to pollution. What are your thoughts on that, if you have any? And do you think that that might be one way, since we have a physician audience and a clinician audience here today, we'd be interested to hear your thoughts.
Well, first of all, I will say I'm not familiar with that evidence at all. And what I am familiar with is the evidence on NSAIDs and just being used as a preventive agent for dementia. And it is a very mixed bag. It is a mixed bag because some NSAIDs have cardiovascular effects. And this could end up being a counterweight against any of their anti-inflammatory effects, which we would expect to be useful in preventing dementia. So the other aspect of this that is kind of tough to wrangle with, I think, is that I guess it concerns this element of agency. So there is definitely a sense, and who can blame anyone for wanting to feel like you have control of your dementia future. And often when we speak of air pollution, people feel pretty helpless. It's like, well, I can set up filters in my house. I can take some other measures, but ultimately I have very little power to control, say, the amount of coal that's burned 100 miles away, for example. And so who can blame anyone for wanting to try to counter those effects by taking, say, some ibuprofen? So on the other hand, this, refocusing on air pollution is, I think, a way to remind people that, in fact, there are elements outside of their own control. So, in fact, if they do get ill, it is not entirely their fault. and I think that's more of a public health centered approach. So I mean, without sort of commenting on the quality of the evidence whatsoever, I want to sort of go back to some conceptual points as well. So that's where I put things right now. But I think it's certainly an interesting idea.
Well, thank you so much again to our expert faculty for those outstanding presentations. So our next panelists will address how clinicians can mitigate the health effects of air pollution-driven climate change. I would like to introduce Dr. Alexander Rabin, who's Assistant Professor of Medicine at the University of Michigan and at the VA Ann Arbor Healthcare System. Dr. Rabin is a practicing pulmonologist with a long-standing interest in the intersection of climate change and respiratory health. Dr. Rabin.
Thank you so much, Brita, and I'm honored to be a part of this presentation today with so many distinguished guests. So I will be speaking today about air pollution and climate change, and I've entitled my talk "Two Birds, One Stone" because
Looks like your slides are not showing, Dr. Rabin.
oh, I'm sorry.
Yeah, I see the spinning circle.
Okay. Can you guys see my slides now?
No, we cannot.
Okay. It looks like it's a full screen. I'm sorry.
That's okay. We'll work this out. I can share them on my end, and then you would just tell me when to switch the slides as another option.
Sure, that's fine.
Okay, so I'm going to add this to the stream. So you just alert me when you need to switch.
Okay. Can you guys all see my slides now?
Yes, we can.
Great. Okay, perfect. Sorry about that. Perfect. So I have entitled my talk "Air Pollution and Climate Change" because as a clinician, as primarily a clinician, we are dealing with the health effects of climate change on a almost daily basis, and it's really, these two issues are inextricably connected. So next slide. Thank you. I have no relevant financial conflicts of interest, and I am a employee of the VA, but these views do not represent that of the VA or the federal government. Thank you. Next slide. So we all know about many of the climate impacts on respiratory health at this point, and we had so many distinguished epidemiologists already speaking to that. But I wanted to highlight just a few of these that are clearly impacting the health of our patients, particularly vulnerable populations, including those with respiratory conditions and chronic lung disease, which are the patients that I primarily see in my clinical practice. And we're seeing impacts really across the country, whether it's on the East Coast or the West Coast. And that includes, of course, heat waves, severe heat waves that occur in the summer and really affect patients, particularly those who are in urban locations and suffer from urban heat island effects, that of severe particulate matter increases related to wildfires, as Dr. Domenici and others have spoken about today. And of course, impacts on healthcare infrastructure, as illustrated by the flooding scene here in New York City during Hurricane Sandy, Superstorm Sandy, which disrupted healthcare delivery, but also even far and wide disrupted supply chains and availability of certain medications, including IV fluids. Next slide, thank you. And again, as many of our prior speakers have already indicated, air pollution is clearly a major global problem and is considered to be one of the top leading causes of death, estimated to be linked to greater than 3 million premature deaths across the world, and over 100,000 deaths linked to air pollution just in the United States alone. Thank you. Next slide. Next slide. Thank you. But if it comes down to it, I always like to quote one of my personal heroes, Bill McKibben, who really said that if one wanted a basic rule of thumb for dealing with the climate crisis, it would be stop burning things. And the optimistic side of the coin is that when we do stop burning things, when we stop exposing vulnerable populations and patients to combustion products, it really works. So next slide. And this has been shown in a number of studies. This table is adapted from a paper that was published in the American Journal of Respiratory Critical Care Medicine a couple of years ago, showing that at different time points after interventions are begun, there are frequently immediate health benefits. And one of my favorite examples, natural experiments, if you will, are related to the Olympic Games. And with the Atlanta Olympic Games, for example, in the 1990s, after just 17 days, there were decreases in emergency department visits and childhood asthma hospitalizations in the Atlanta metro area. Similarly, with, for example, addressing emissions related to stoves, over the term of a mother's pregnancy, there were pretty impressive improvements in birth weight and decreases in perinatal mortality. So addressing emissions on a very local level, on a regional level, has quick and dramatic impacts on the health of our patients. Next slide. And this is another trial, study that was published surrounding the Beijing Olympics. And this one looking more specifically at biomarkers of taken from patients taken from patients during BALs, or bronchial alveolar lavages. And what you could see is that after the power plants were closed in preparation for the Beijing Olympics and emissions were dramatically reduced, there was significantly less inflammation among subjects in this study. Next slide. And another paper put out now, oh gosh, about almost 10 years ago, has shown that among children with asthma, by cleaning up bus fuels, and this is not even necessarily electrifying buses, but just modifying the type of fuel that's used and the way that the fuel is combusted within the bus, they showed an impact on absenteeism in school. So again, fairly simple, one could say cost-effective interventions seem to have direct impacts on the health of our patients. And again, emphasizing that these are vulnerable people, and these are young children with asthma. Next slide. This was raised by Dr. Lundberg just a few minutes ago. And there is interest actually in NSAIDs and specifically aspirin as a potential modifier of air pollution effects. This group has now published a couple of papers. One in the American Journal of Respiratory Critical Care Medicine that was published a few years ago, looking at impacts on lung function. And then more recently, last year, a paper looking at potential effects on cognitive performance among veterans. And this is a VA study, long-term VA study from the 1960s that's been following patients over a long time. And they essentially have shown a link between short-term exposure to air quality, poor air, as measured by particulate matter and carbon exposure, and seem to show that there is an attenuation of that impact on cognitive performance when folks are taking NSAIDs. And again, mostly the NSAIDs are aspirin. I would say this is still kind of hypothesis generating, and more studies need to be done in larger populations, but it is something to note, because of course, as clinicians, we want to not just counsel patients, and try, we don't want to just inform them, but we want to actually try to help them. So this is another thing. Hopefully, we'll be learning more over the next few years. Next slide. Because when it comes down to it, I'm a clinician first, and spend most of my time seeing patients in the lung clinic. And I just wanted to highlight that these impacts on patients are real. And so, you don't have to look very, very far to already see impacts of climate and poor air quality on our patients. And so I wanted to illustrate this patient who actually I've been following for a few years now. She's a 42-year-old elementary school teacher, and I was previously on faculty at Tufts Medical Center. And she came to me with recurrent episodes of dyspnea, wheezing, and cough. And this patient had gone to the emergency department numerous times. She'd had multiple courses of prednisone, and she'd seen a pulmonologist on the Cape where she lived, but was just not seeming to respond to normal asthma treatments. We did pulmonary function testing, and she had some mild obstruction, but they didn't. Her spirometry did not seem to necessarily reflect the degree of her symptoms that she was reporting, particularly when she was at work in her school. And her symptoms were clearly improving during holidays when she was away from the school, and they were worsening when she was at school during the school year. She had some markers of inflammation and allergic signs of allergy, including an elevated serum IgE, and she had an elevated peripheral eosinophil count. And most interestingly, as I got to know her over a couple of visits, she revealed to me that actually other teachers in her school were reporting similar symptoms. Next slide. And this is not exactly her school. I wanted to protect her identity, but this is a school similar to hers. And as it turned out, I ended up seeing 2 more staff members from this school. And what was going on was absolutely, to me, it was fascinating as somebody who was a little bit more attuned than perhaps your average pulmonologist to climate impacts. What was going on was that the school had some air conditioning units, but did not have central air conditioning. And during the summer, in order to save costs, basically they were not running any air conditioners. And as the temperatures on the Cape during the summer were higher than expected, the humidity was extreme inside the building, there was an unbelievable buildup of mold in the air ducts. And as we investigated further, we ended up initiating a state investigation into the school, and I actually got a report about a year later that just documented, incredible, just unbelievable images of mold buildup within the air ducts systems of the school. And again, this was a school that was around for many, many decades, yet they had not had any kind of problems like this in the past. And one can only say that it was likely that there was some relationship to the increased temperatures and the increased humidity. Next slide. And we diagnosed this patient ultimately we diagnosed her with work-related asthma and what's called sensitizer-induced asthma, which is an IgE-mediated allergic type of asthma. Next slide. And so what we did to intervene was the school agreed to perform a mold abatement. They installed additional air filtration systems. And actually, my patient only really improved, ironically, with the COVID pandemic, because she was able to teach from home. And it was just a dramatic improvement in her symptoms when she was at home as opposed to at work. We also counseled her on preparing for extreme heat events, and we spoke a lot about peak allergy season. Next slide. So as a pulmonologist who sees patients like this, who clearly have impacts of climate change on their health, and suffer from sensitivity to extreme heat and humidity, I try to counsel my patients on air quality index alerts. We talk frequently about preparing ahead of time, and sometimes we will even prescribe prednisone or other steroids so that patients are ready for these extreme events. We talk about cooling plans and where they're going to go if they don't have access to air conditioning. And there's a lot of increased interest now in air filtration and HEPA filters. And while the evidence is still mounting that HEPA filters may be helpful, there is for those who really don't have any choices, like this patient in this school, HEPA filters did seem to make an impact. So I'll be excited to see where the research goes on that. Next slide. So thank you again for having me. And I also just wanted to leave us with this quote, which is that, the atmosphere is a communal space and lungs are an extension of it. And so, we are all, even, all of us breathe the same air, no matter our socioeconomic status. And so it's our duty to try to clean it up and help all of our patients. So thank you very much again for having me.
Alex, thank you for that fantastic talk. Amazing data, especially on school absenteeism. Our next speaker is Dr. Philip Landrigan, who is a pediatrician and epidemiologist. He directs the Program for Global Public Health and the Common Good at Boston College. His research examines the health impacts of toxic environmental hazards. He co-chaired the Lancet Commission on Pollution and Health. Since 2019, he's led the Monaco Commission on Human Health and Ocean Pollution. Thank you, Dr. Landrigan.
Thank you, Britta, and thanks, Dr. Raven, for a great clinically oriented talk. So important to get ground truth from real patients. Jason, you're going to advance my slides, right?
Correct.
Okay. So the first slide here is my title slide, The Health Impacts of Air Pollution in the Cities and Towns of Massachusetts. And I'll be reporting on a study that's currently ongoing, not yet quite complete, from our Global Observatory on Pollution and Health at Boston College. So the next slide shows that air pollution is the world's largest environmental cause of disease and death, are responsible for an estimated 7 million deaths globally each year. That breaks down into between 4.5 and 5 million deaths per year that are due to ambient air pollution. And that picture in the background is Cleveland, Ohio. In 1968, a couple of blocks from Cleveland Metropolitan General Hospital, where I was an intern that year. That's the kind of pollution we used to have in this country. And ambient air pollution is rising rapidly, especially in East Asia, South Asia, and beginning to rise in sub-Saharan Africa. And it's been projected that in the absence of aggressive intervention, it's going to kill twice as many people by 2050 as it kills today. At the same time, we have household air pollution responsible for between 2.5 million deaths per year, and fortunately, fortunately, those deaths are coming down in number as governments around the world advance efforts to control household air pollution. Next slide, please. In the United States, we have made remarkable progress against air pollution since 1970, when we passed the Clean Air Act. The main provisions of the Clean Air Act are shown on this slide, and the Clean Air Act remains the principal air pollution control law in the United States today. The next slide, please, shows the progress we've made Jason, can you get my animation there or not? Is it showing? I guess not.
Sorry,
Okay.
I'm sorry. It's doesn't seem.
It's not okay. Anyway, there was supposed to be animation there showing that in Cleveland, from the dirty air of 1968 on the left to downtown Cleveland today, a much cleaner place, the Cuyahoga River that you see there used to catch on fire. Now it's a national recreation area. And the graphic based on EPA data shows that emissions of the 6 principal air pollutants have come down in the USA by 74%. Really an astounding decline since 1970. And that, by the way, has been highly cost effective. Reflecting on Dr. Clay's presentation, the EPA estimated a few years ago that every dollar invested in air pollution control since 1970 has yielded $30 in return. Next slide, please. But progress against air pollution has stalled, especially during the last presidential administration between 2017 and 2020. For the first time in nearly half a century, we saw increasing levels of air pollution and increasing air pollution-related deaths for the first time in nearly half a century, with those increases, not surprisingly, being most severe in low-income and minority communities. And these increases followed rollbacks in federal standards and relaxations of enforcement like the mercury and air toxic standards. Next slide, please, shows a graph. This comes from a Lancet report published about a year ago, a large commission on which I was a member. And you can see that since the 1980s, approximately, air pollution levels have been declining in this country, but starting in 2017, over at the right-hand side of the slide, they bumped up. Next slide shows where those increases occurred, and ironically, the biggest increases in air pollution and in air pollution-related disease were in red states that voted for the previous president. These are states that are heavily industrialized and also have traditionally weak state-based air pollution control programs. State programs can buffer, to some extent, they can buffer relaxation and federal controls. Obviously, state-based regulations can't control the movement into New England of pollution from the Ohio Valley, but at least it can control emission sources here. But across the country, things got worse in the last 4 years. Now we're beginning to turn the corner. So what's the current burden of air pollution-related disease here in Massachusetts? Next slide, please. We're conducting this study, which is supported by the Barr Foundation. The study was inspired by Tip O'Neill's maxim that all politics are local, and we said to ourselves, well, in a state like Massachusetts, where public health is a local function, city and state boards of health, let's look at the impacts of air pollution on the burden of disease and death in each city and town in Massachusetts. And we decided also, building on the new data that Dr. Werve was talking about this morning on the impacts of air pollution on the central nervous system. She had talked about impacts on the aging brain. There's also information that air pollution exposure in early life causes IQ loss, increases risk of autism, increases risk of attention deficit disorder in children. We decided to estimate the impacts of PM 2.5 air pollution on IQ loss in children, and two colleagues that were key to that work were David Bellinger at Boston Children's and Maureen Kenny at Boston College. We also reckon that by doing this study, we could create a model that other states could use. We figured that if we could show that air pollution causes disease right in the place where people live, that it's not remote, that it's not far away, that would catalyze action. And this is a replicable model. Next slide, please. So we got data on PM2 levels from the Mass DEP. We use the US EPA's BENMAP program to compute the burden of disease and death in each city and town in Massachusetts. And we created our own concentration response coefficient to measure the impact of PM 2.5 pollution on IQ loss, because no such exposure response coefficient has yet appeared in the literature. So we built our own. Next, please. And this is what we found looking at from the state data, air pollution levels by county. It's interesting that across Massachusetts, air pollution levels are substantially below EPA standards. The EPA standard is 12 micrograms. The mean across Massachusetts is 6.3, with a high of 8.26 in Suffolk County. So we're not talking about massive elevations in air pollution. And please hold that thought in mind as we talk about the impacts of pollution on disease and death in Massachusetts. Next slide, please. These are the sources of air pollution in Massachusetts. Roughly 2/3 of the 900,000 tons that are released to the air each year in the state come from mobile sources, which means that any action that we take to improve public transportation, for example, is going to have substantial effects in reducing pollution. And then approximately 1/3 comes from stationary sources. And it's important to point out that more than 95% of this population, for both stationary and mobile sources, results from the combustion of fossil fuels. And thus it links back to the earlier talks we heard on the link between air pollution and climate change. Next, please. Sorry that we don't yet have final computations on our numbers. We had hoped to have it by today, but we hit some snags with the software, so we'll pass on that slide. Next, please. Okay, but I want to talk about why we decided to look at IQ loss in the study. First, obviously, there's been controversy about IQ, but controversy aside, the IQ has been very widely used, and is particularly relevant here because IQ loss has been used to assess the effects of lead, mercury, pesticides, and brominated flame retardants on children's brain development. And multiple studies have shown that exposures to those toxic chemicals are associated with IQ loss. So we figured we would use it here. The IQ score measures both verbal and nonverbal abilities. IQ scores are very highly correlated with children's academic performance and with their scores on standardized tests, with high school graduation rates. And when IQ loss is widespread across the population, it can pull down the average intelligence of the whole population. And then, very important from the point of view of equity and social justice, is to point out that in low-income communities that are highly polluted, that pollution-related IQ loss related to air pollution can magnify the negative effects of poverty, structural racism, psychosocial stress, and other toxic hazards like lead. Next slide, please. And this little slide shows the impacts of IQ loss on societies. And this slide shows that the reduction in the average IQ of a population by as little as 5 points. And remember that IQ is scored on a 200-point scale. So reducing IQ by as little as 5 points on a 200-point scale results in a 50% reduction approximately in the number of really gifted children with IQs above 130, the future leaders of any society, and at the same time a corresponding increase in the number of challenged children, kids who are more likely to require special ed, have difficulty in school, may have difficulty in employment and independent living when they become adults. Next slide, please. So what's the way forward? We've all talked about it this morning. I'll just underscore a few high points. That slide is a clue. Next slide, please. The first point is the very positive statement that disease, death, and IQ loss caused by air pollution can be prevented. And the proof of that statement, the evidence, is the simple fact that we've achieved a more than 70% reduction in air pollution in this country through the wise and judicious application of laws and policies and regulations that are based on science, backed by enforcement, and encouraged by incentives. We know how to do this. And the key here, the impediment really at this point in time, is not science, nor is it technology. It's politics, and it's political will, and it's the power of vested interests. And what we have to do is be bold. We have to take evidence-based action. We have to confront vested interests. We have to stop pollution at its sources. Next slide, please. And here are some recommendations for cities and towns. Convert the municipal fleets to fully electric, solar panels, purchase electricity from renewables, block construction of gas pipelines, compressor stations in their towns. We've seen this construction in the past year or two of a natural gas compressor station in North Weymouth, right in the middle of a densely populated environmental justice community. This speaks directly to Danny Faber's data from an hour ago. We also need to prohibit gas hookups in new construction, as several towns like Brookline have recently done. And we need to revise building codes to increase energy efficiency. Next slide, please. And then at the state level, Massachusetts authorities need to work with EPA to reduce the current PM 2.5 standard of 12 micrograms, which is clearly too high. We're seeing disease, death, and IQ loss at levels below the EPA standard. The World Health Organization has recently lowered their recommended guideline to 5 micrograms. The US should do at least as well. DEP needs to place more air monitors. There's only 14 or 15 air monitors across the state. Air monitors are especially lacking in poor, minority, socially vulnerable communities. DEP needs to publish an annual, accessible, readable emissions inventory. It took us days to figure out how much pollution is being released into the air in Massachusetts. It shouldn't be that way. People should be able to go online the same way they do for the COVID dashboard and find out what is being released into the air in the state. And likewise, the Department of Health needs to publish a dashboard on the burden of pollution-related disease and death in each state. We're going to make our data available to the state as soon as we finish our computations. And finally, the state needs to increase incentives and tax breaks for solar panels, windmills, and geothermal installations. Next slide, please. At the national level, what's really needed in this country, and we all know it, is a massive transition away from fossil fuels towards renewables. To sustain that, to push it along, we need to urge ISO New England, which is the operator of the region's power grid, to favor renewables over fossil fuel combustion. Right now, they're not even letting renewables gain access into the power grid because they threaten the monopoly of the fossil fuel industry. We have to get off gas. It's just another addictive fossil fuel. We need to end subsidies. And most of all, we need to resist any temptation to move to nuclear power. Let me close with the last slide, the next one, please. The penultimate slide. Here's the good news. The cost of producing electricity from wind and solar power has dropped remarkably. In the case of solar power, the costs have come down by 90%. In the case of wind power, by 60%. That horizontal gray band across the slide is the cost of producing electricity from fossil fuel. You can see from those descending lines that in the past decade, in most places around the world, it's become cheaper, actually cheaper, to produce electricity from wind and sunshine than from coal, gas, or oil. And now my last slide, which is next one, please, is the last slide. Hardly need to introduce Bernie Lown to PSR, but let's all remember what one committed physician like Bernie Lown could do. He and his colleagues in the then Soviet Union got together across the Great Divide of the Cold War. They built on PSR's work to found IPPNW and were awarded the Nobel Peace Prize. It's an example of the power that we health professionals have to speak truth to power and to achieve societal reform. We can do this on air pollution. We can do it on climate change. We need to get together exactly as we are this morning and speak up. Thank you very much. And now I'd like to pass the podium to my friend and colleague, Dr. Sanjay Rajagopalan.
Thank you so much, Phil, for that outstanding presentation. So inspiring, with a really great roadmap to all the preventive measures that we physicians can be asking for in our work and in society. I would now like to present Dr. Rajagopalan, who was not able to be with us today and kindly pre-recorded his talk. He is Chief of Cardiovascular Medicine, Professor of Cardiovascular Research, and Director of the Case Cardiovascular Research Institute at Case Western Reserve School of Medicine in Cleveland.
Good morning, and again, it's great to be here, albeit remotely with you, and I'd really like to thank the organizers of this very important conference, the Greater Boston Physicians for Social Responsibility, for this incredible opportunity to speak about cardiovascular health effects of climate change and how do we mitigate it. So let me start with my first presentation, which is really a slide to acknowledge the work done by Jeffrey Rose, who very prophetically said many, many years ago that science alone can't heal a sick society. And he could not have been more right, because we now know that the primary determinants of disease in many instances are economic and social, and therefore the remedy is also economic and social. Medicine and politics cannot be kept apart. And I didn't say this, Jeffrey Rose did. And here you have a little picture of a tombstone lying in rest in London. As you can see a very polluted landscape in London, even going back a few decades ago. And now fast forward in 2008, you can see a much, much cleaner London. And this is so true of many cities across Europe and North America. And I think when you start to think about larger problems like the environment, in particular climate change and air pollution, one cannot frame the issue without talking about the larger issues that one needs to solve. So let me start by acknowledging the contribution of environmental pollution and health. And this is taken from the wonderful article that Dr. Phil Landrigan led in The Lancet a few years ago now, which has been cited thousands of times, which acknowledges the impact of the environment and pollution to overall mortality across the globe. And this is 9.1 million deaths. And many of us know that the footprint of environmental pollution is perhaps much larger than this. Now, it's often surprising to physicians to note that more than 50% of deaths attributable to environmental pollution, and in particular air pollution, is from cardiovascular disease. And this is taken from the Global Burden of Disease study in 2019, where one way to conceptualize the footprint of environmental pollution is to look at it in terms of a pyramid, and looking at it in terms of well-characterized adverse effects, or zone 1, where we know direct links between pollutants like air pollution, where it's being strongly associated now with thousands and thousands of epidemiologic studies in all-cause mortality and cardiovascular mortality. And zone 2, where there's emerging evidence, but still unquantified, a burden of disease from a number of other factors. And in particular, now we know links between air pollution and hypertension, diabetes, and diabetes was included in the global burden of disease attributable to air pollution, in light of the growing and now pretty solid evidence linking the factor in the genesis of type 2 diabetes mellitus. And finally, in zone 3, where there's emerging associations and there's need for further research. In particular, when examining PM2.5, and I know there are many other very illustrious speakers that are going to be talking about this today, we now know that the levels in the United States, thanks to legislation and work done over the last 4 decades, are mostly well below the national ambient air quality standards of 12 microgram per meter cube. And in the slide towards your left, you can see levels in the United States, which continues to decrease very nicely, well below NAAQS levels for most of the United States. And in contrast, in China and India, and certainly global levels, which continues to be a major problem. We also know a lot about the dose-response relationship, and this is the GEM model for ischemic heart disease mortality, depicting relative risk on the y-axis, and PM2.5 dose on the x-axis, showing that there's absolutely no threshold below which you see risk. We see continuing risk well below levels of 5 microgram per meter cube in this country. Now, it's also important to note that there's persistent disparities in air pollution exposure across the United States. Now, this is a very interesting exercise that was published in Science just about 2 years ago, showing the relationship between changes in air pollution in the United States when divided across 65,000 census tracts. And this is looking at air pollution levels and the way things have changed from 1986 to 2016, 1981 to 2016. And you can see a heat map on the left side where we see areas in the Midwest surprisingly experiencing clean air quality, whereas many areas in the southwestern United States and the west coast of North America continue to see deterioration, compared to the past. On the right side is a very clever depiction of the changes in PM2.5, depicted by changes in percentile ranks in 2016 on the y-axis and percentile rank in 1981. In other words, how did census tracts do in 1981 when contrasted with 2016? And you'll see this line in the center. And for the most part, there was reductions. In other words, towns that had very low levels of air pollution, for instance, remained so, but there were some that deteriorated, one could say. Very importantly, towns that were the worst percentile on the top, on the right-hand topmost corner of the graphic, actually did lower their air pollution level, but did not do so disproportionate to the towns that were at low percentile ranks. One would have liked to have seen a much, much greater shift at this level, just denoting the fact that there needs to be much more work that needs to happen in this area. Now, we now know that very low levels of air pollution increase risks. This is a Canadian health survey study involving 300,000 patients with mean PM levels, which are, for the most part pristine at 6.3 microgram per meter cube, showing a persistent 19% increase in cardiovascular risk for every 10 microgram per meter cube. And here, right here in North America, from a Medicare population, this is from Dr. Schwartz's paper, along with D et al. In New England Journal published a few years ago, showing that in the Medicare population of elderly patients, every 7% increase in mortality is seen with 10 microgram increase in PM2.5. And in particular, there was seen to be a disproportionate risk amongst Black, Asians, Hispanics, and Medicaid patients who happen to be at higher risk. And again, the mean levels are slightly higher than our pristine neighbors due north at 11 microgram per meter cube. But then again, there's been, even within the last 5 years, there continues to be a remarkable shift towards cleaner air pollution levels. Now, we've also learned that socio-environmental risk scores, or social determinants of health, are powerful predictors of risk, as was shown in the Medicare study. This is a nice exercise put together by Dr. Sudhir Al-Kindi, who's a junior faculty member here, that looked at 27 census-tracked socioeconomic variables, including income, education, housing, transportation, a variety of different environmental variables, light pollution, noise pollution, across the United States, and used a machine learning algorithm to sort of look at what the association is between socio-environmental variables and prevalence of CAD. And indeed, there was a very, very powerful relationship or correlation when using a machine learning algorithm to perform this analysis. What we also know is we have had a substantial change in our understanding towards how air pollution could modulate cardiovascular disease. We now understand that there are very interesting links, neurobiological models that connect not only environmental stress, but clearly psychosocial risk, including depression, where increased stress due to a variety of different factors activates key centers in the brain, including the amygdala, that activates sympathetic nervous system circuits, and also increases hypothalamic pituitary adrenal axis and causes systemic inflammation. And the systemic inflammation in turn results in predisposition to a variety of different diseases, including hypertension, insulin-resistant adiposity, and ultimately cardiovascular disease. Now, this is, I guess, the most important part of my talk, which is the link between air pollution and climate change. And I don't have to tell this audience about the links, but very oftentimes I have to reiterate this to physicians to recognize that the emissions from the same anthropogenic sources that emit climate change or carbon dioxide also affect cardiovascular health. And in this sense, framing climate change and actions related to it could go much better with individuals, including the lay public, when you frame it from the health perspective. So the focus should always be on air pollution when talking about climate change. Now, one of the most important, in my opinion at least, a contribution to the COP26 COP26 conference was this special report on climate change and health. And this is ostensibly, in my mind, at least the first serious attempt where the climate change panel has really started to talk about the health argument for climate action. And they were very meticulous about detailing 10 steps, and you can look up this document, by which you can start to address the health effects of climate action, starting with commitment to a health recovery, that health is not negotiable, and finally ending with listening to the health community and prescribing urgent climate action. And this again makes a call out to linking the health effects in order to force change. We now are surrounded by dire statistics. There's not a day that goes by when you open up your newspaper and you look at what's going to happen in terms of a dismal outlook of meeting the Paris Agreement target of 1.5 degrees centigrade. And literally, we need to redo the COVID-19 pandemic. At least in the initial phases of the pandemic, there was a roughly 7% decrease in emissions. And the sobering part of this is you need to repeat this every year for the next 10 years. And even if you did that, there was a recent editorial published in Science that says even updated pledges executed as written in the United Nations Climate Change Action Committee will result only in reductions of 1% by 2030. So these are some really sobering statistics. But moving forward, there are some bright spots. This is a 2035, the report, a consensus document, a scientific document put together by the Goldman School of Public Policy, which really argues that the tremendous decrease in solar, wind, and battery costs will indeed accelerate our clean energy future. And this is certainly within the realm of reality, where consistent reductions in emissions, because of widespread adoption of wind, hydro, geothermal, and biopower could fuel a clean energy future where it would be possible to eliminate coal by 2035, and at the same time reducing natural gas consumption. But this is only going to happen through major infrastructural investments, as well as a massive expansion to wind and solar energy. So I think there are some optimists who continue to believe that this is certainly possible. And by doing so, this 90% clean grid would avoid $1.2 trillion in health and environmental damages, including 85,000 premature deaths through 2050. And we all know that the math of this is relatively straightforward. Every single time there's been an investment in these types of initiatives surrounding clean energy and initiatives to reduce air pollution, it's always economically feasible. So the economic justification, I think, is already done. We now know that investment in areas like this will indeed turn out to be profitable. What can an individual do in the meantime while we wait for our government to make these changes and bring about these huge shifts in transition that are required to move to the clean energy economy? Well, one of the things that could happen is to take every effort possible to reduce exposure. And in collaboration with a number of different people in the American Heart Association, we put out a document that really precisely puts together protective actions that one could take in order to prevent adverse exposures to particulate matter. And this was published in Circulation in 2020. It starts with being aware of your environment. There are many areas in the United States, in particular the Western seaboard, as well as the mountain states, where there is a real hazard for forest fires, where there's potential for exposure to very high levels. So being aware of your exposures is very, very important. And there are a number of sources where we can actually get levels, daily levels of PM 2.5 levels. And in order to make this very simple, we frame this from that perspective. Start with being aware. And if you're especially a special demographic, in other words, you tend to be at higher risk for cardiovascular disease. In other words, people with established cardiovascular disease, prior heart attacks, strokes, prior hospitalizations, people who have heart failure, COPD, asthma, patients who have very high risk by virtue of having multiple risk factors, chronic kidney disease, patients with transplants, the elderly, right, would be very well served by paying attention to air pollution levels, and consider acute measures if your levels are dangerously high, if they're hazardous, if PM 2.5 levels of greater than 300, for instance. And for that matter, if you happen to live in areas where there's reason to believe that there's chronic exposure potential, defined as annual PM 2.5 greater than 12 microgram, do consider long-term measures, and this includes a variety of different personal measures. Obviously, and the personal measures include things like wearing an N95 mask, avoiding commutes in heavily polluted areas, considering alternate routes of travel, for instance. And if you happen to be indoors in a very heavily polluted environment, do consider using air conditioning, change the filters very often, and obviously partake in healthy activities, including exercise, as well as taking cardioprotective medications. There's no question that societal and governmental strategies are absolutely implicit in all of this, and we need a very engaged government in terms of providing critical infrastructure upgrades, clean energy incentives and transition. The energy sector hopefully will come together in terms of reforming, as well as the transportation reform that needs to happen in this country, given the fact that more than 50% of emissions in North America comes directly from transportation. And finally, ecosystem changes, including a major attention to urban redesign, relocation of communities, relocation of traffic, for instance, and building abundant green space, because that's a well-known intervention to reduce air pollution. I would be remiss in my presentation if I did not acknowledge the important contribution of healthcare organizations to air pollution and climate change. This slide is taken from a very important document from Healthcare Without Harm that depicts the overall contributions in North America or the United States of healthcare organizations, which contribute to as much as 7% of greenhouse gas emissions. And the vast majority of this actually comes in from scope 3 emissions, or emissions related to the supply chain of healthcare, particularly things like pharmaceuticals, non-capital medical devices, capital goods, and waste generated by facility operation. The document also goes on to recognize 7 key steps that might be important in this transition by which healthcare organizations can directly reduce the burden attributable to greenhouse gas emissions and air pollution. Healthcare organizations, by doing so, can lower costs because there's an economic incentive by shifting to areas and activities that might save healthcare costs. They can also impact communities that they live in by reducing air pollution and averting healthcare effects. And finally, obviously play their role in climate change mitigation. Again, I'd really like to thank the organizers for putting together this very impressive symposium. It's really a pleasure to be part of this. And I'd like to conclude by thanking all my collaborators whom I've had the distinct privilege and pleasure to work with over the last 20 years. Thank you very much.
Thank you, Sanjay, for that excellent talk and comprehensive overview. We will now move to our question and answer portion of this hour's panel. As a reminder to our audience, if you have questions, please do type them in the comments section. I apologize for not catching all the comments earlier. And we will start with a question for Dr. Landrigan from Jacob Adams, I apologize. Jacob asks, why IQ loss as opposed to IQ? And then he clarifies saying, did you measure IQ loss, or did you measure IQ over time, or simply IQ at one time? And his second part of the question is there a reason for measuring change in IQ or a single point measurement?
Yep. So to clarify, we did not do any direct measurements of children's IQ in our study at all. What we did was we developed a model based on a systematic review of something like 6,000 papers that had looked at correlations between air pollution and neurologic dysfunction in children. And we computed a correlation coefficient that every 1 microgram increase in PM2.5 level resulted in the loss of, I believe it was 0.41 IQ points. So we're not measuring change in IQ over time. We're measuring loss of IQ against a counterfactual of there being no air pollution.
Wonderful, thank you. Alex, a question for you. Can you talk a bit about the state of clinician involvement in environmental advocacy? What prevents clinicians from playing a bigger role? What are we doing well? And what's the most meaningful way clinicians could get involved? And actually, both of you could answer that.
Yeah, that's a great question with a lot of answers, I guess. Well, what I see from my vantage point within the academic medical environment is that there is a groundswell of interest, particularly among medical students and trainees. And I see these young health professionals as really driving a lot of the change right now. But of course, in my view, that is necessary but not sufficient. We also need leadership from the top, and of course, seeing, for example, Dr. Rajagopal, who I'm not as familiar with previously, but seeing somebody in that stature, speaking to this is really powerful. So I think that you need input from trainees, the sort of the ground troops, and you also need leadership from the top echelons of our healthcare system to be driving change. And so I have seen, again, in the last 5 years, really just a groundswell of interest on these issues. And there are so many ways to get involved these days as clinicians, whether that's participating in educational events, as we're doing today, whether it's doing direct advocacy at the local, state, and national levels, whether it is leading quality improvement projects, within the clinical environment. For example, I am working with some residents and students right now who are working to eliminate certain anesthetic gases within operating room environments that have high greenhouse gas potential. So there are really a lot of opportunities, and I think making use of organizations like this one, like Healthcare Without Harm, can help magnify those impacts. So that's a short answer, I guess, to the hard question.
Rita, could I do a quick follow-on to that?
Absolutely. You had a whole slide and we cut you off, so we would love to hear more about that.
Brita, can I do a quick follow-up to what Alex said?
Absolutely. Phil,
Yeah.
please do.
So firstly, I concur totally with what he said. The groundswell is really quite amazing. And let me just offer two specific observations that reinforce that. First of all, coming from down below, from the young, I'm now teaching public health to undergraduates at Boston College. So I moved from a medical school to an undergraduate environment. The groundswell is even more powerful among these undergraduates than it is among the medical students. And I think what that represents is a forward-moving wave of concern in our younger population. Secondly, the good news from the top is that the Institute of Medicine, now the National Academy of Medicine, has now established a section on climate change, and the president of the NIM, Dr. Victor Zhao, is taking this stuff very seriously. I think we're achieving a conversion at that level. So I'm cautiously optimistic.
Fantastic. Thank you both for that. One last question, probably this would be for Alex. Eric Grunbaum says he'd be interested in studies on tree canopy and pulmonary health benefits. Would you be aware of any such studies? Because he is working on a project to expand tree canopy in EJ neighborhoods in Cambridge.
Great question. I will admit I am not directly as familiar with the research. I am familiar with, conscientious tree planting, particularly planting those trees that have less allergic potential that may, so we have to be mindful of exactly what types of plantings we're putting in neighborhoods. But in general, of course, there's great benefit we know for decreasing urban heat island effects. I forgive me for not having as direct information at my fingertips, but that's a great question.
Thank you so much. Thank you so much to both of you. Thank you to our expert faculty for these excellent talks. And we'll move on to our next panel.
Thank you.
Our next panelists will address community solutions to air pollution. I would like to introduce our first panelist, who is David Wittenberg. David is Assistant Attorney General, and he prosecutes environmental crimes for the state of Massachusetts. He is a lead co-author of COVID-19's Unequal Effects in Massachusetts, Attorney General Maura Healey's report on the intersection of COVID-19 and environmental justice. His office led the successful effort to save hundreds of mature trees on Boston's Melnia-Cass Boulevard, so perhaps he might have some answers to the question that Eric Grunbaum just posed earlier. Thank you, David.
Thank you so much, Britta, and thank you to all of the prior panelists. It's been a really fantastic morning so far. Well, let me introduce myself a little bit. So I'm David Wittenberg, and as Britta said, I'm an Assistant Attorney General in our Environmental Crimes Strike Force. So what does that mean? Well, my core work is in prosecuting environmental crimes and doing civil environmental enforcement. So meaning releases of asbestos, lead, and other substances under the Clean Air Act, under the State Clean Air Act. We work on idling cases as well, and then also dumping of toxic substances. We do some wetlands cases. In addition, I also work on our case where we're suing Exxon over deceiving the public over climate change and its effect on health and on the company's investments. And finally, I've been really privileged over the past 2 years to do some really interesting work at the intersection of environmental justice and public health. I'd like to speak about that a little bit with you this morning. We've talked a little bit about environmental justice so far this morning, and I think it's just really important to ground ourselves in some first principles. My colleague Daniel Faber, who spoke on our first panel this morning, talked about how Massachusetts had some of the greatest inequality in the country when it comes to citing of polluting sites and toxic waste sites near poor communities and communities of color. And this is really borne out in some of the statistics about economic inequality in Massachusetts, and I think this is sometimes, if you live in Greater Boston, this is something that you might not think of all the time, but Massachusetts has 1 in 8 children living in poverty. It's 4th in the nation in income inequality, meaning the ratio of median household income at the 80th percentile to household income at the 20th percentile. This is along with New York, Louisiana, and Mississippi. The number of homeless families at the moment is at an all-time high, with over 4,000 families, including about 8,000 children currently living in shelter. We have 52,000 children as of 2020 receiving temporary assistance for families with dependent children, which is a 34% increase over November 2018. As of a 2019 study, there were 683,000 people in Massachusetts who could have been enrolled in supplemental nutrition assistance programs, but weren't, leaving nearly $1 billion in federal nutrition benefits on the table. So again, I think particularly in the medical and biotech community, you tend to think of Massachusetts as being a really prosperous state, and it is, but it's also a state with a tremendous amount of inequality, and this affects public health outcomes tied to the environment as well. Just a couple of additional statistics. About 90,000 children live in high poverty neighborhoods, so neighborhoods of concentrated poverty where 30% or more of the residents have incomes below the poverty level, which is about $25,000 for a family of 4. There are neighborhoods in Boston, Worcester, Springfield, Lowell, and Holyoke where well more than half of families live with incomes below that poverty line. And as is known, high poverty neighborhoods are often the legacy of long-standing patterns of housing discrimination against people of color, underfunded schools, and poor public transportation. And this is reflected and has been reflected over decades in the siting of polluting facilities. Okay, so what can we do about this? So enforcement obviously is one piece of the picture. Just last Thursday, I indicted landlords in Lowell on 106 counts of violating the Massachusetts Clean Air Act by releasing asbestos in an environmental justice community. That's important, but there are other types of interventions where government can interact with the academy and also grassroots community groups to really, I think, create change quickly in an emergent situation that can really, I think, help to affect environmental justice. So a couple of things that we've done over the past few years. Britta kindly mentioned our environmental justice report on COVID, and I want to talk a little bit about the genesis of that. So Francesca Dominici spoke earlier, and when her initial study on the increase in death rates or excess COVID deaths based on PM2.5 across more than 3,000 American counties came out, that really made us think in the Energy and Environment Bureau at the AG's office about how can we localize this information. And unfortunately at the time, we couldn't because the data wasn't there. The State Department of Public Health was only providing was not providing data frequently enough, and it was only providing data at the county level. And as you may know, we have 14 counties in Massachusetts, and many of them are huge. Middlesex County has more than 1.25 million people. Suffolk County is about 800,000 people, and they're extraordinarily diverse, right? Like, Weston and Lowell are in the same county. So county level data wasn't really going to tell us what we wanted to learn about inequality and COVID infection, morbidity, and mortality, and comparing that against pollution rates, and in particular NO2 and PM2.5. So we worked with Jonathan Levy at the BU School of Public Health, and essentially said, how can we get at this issue, and what do you need from us to get at it? And we were able to find a data set, this grassroots data set really, that was being collected by the Massachusetts Major Chiefs of Police, because they wanted to know if we're going into a house, this is in March of 2020, or if we're called out to a location, is somebody positive in that home? What do we need to know going in? So they were collecting all of this data on case rates, on hospitalizations, and on deaths at a city and town level that wasn't otherwise being made public. So we had this for the 40 largest cities and towns in Massachusetts, which in terms of communities of color was very helpful. There were a couple of places that are very diverse that were left out, like Braintree and Randolph. We were able to get this, thank you for the 3-minute warning, Anna, data to BU and map it against many, many different factors. And what the BU researchers were able to show, I think, is unfortunately not surprising, which is that COVID infection rates, morbidity, and mortality were the highest in communities where there were more people of color, and that this was connected to levels of air pollution, in particular NO2 and PM2.5. This study, was really back of the envelope compared to a lot of the work we've seen today. But I think what it helped to do was to jumpstart state action and local action in city and town boards of health at a time when the pandemic was really fresh. So it's an example of working again with a combination of communities and government and the academy to get something done. Another example is what we did at Melnia Cass Boulevard, where we worked with community groups, associations of residents in public housing, and then folks in the academy and arborists, all sorts of people, to sort of collect information about what was going on with these mature trees and the science on that, and present it to the city of Boston in a way that caused them to stop their plan to cut down all of these mature trees. To answer the question from before, yes, there's a lot of interesting science out there about, in particular, mature canopy and its effects on respiratory health. And that comes from a lot of different sources, some of which we've talked about today. The decrease in humidity, decrease in temperatures is certainly one of them. And planting is really, really good, but preserving existing mature trees is even better, right? The effect of thank you, Anna, for the 1-minute warning. Right. So the mature trees are much, much better at these effects than new trees. So you have to plant some multiple of new trees in order to achieve the same benefit. So at Melnia Cass, these trees were 30 or 40 years old, had actually been planted almost as compensation for the demolition of a large part of the neighborhood that took place in the 60s and 70s as preparation for what was going to be the Inner Belt Highway in Boston, which was defeated by a community effort called the People Before Highways effort. And although these homes were destroyed, they planted these trees in their place, and they had really become a part of the community. So we saw it in that case as really a tremendous injustice of these trees that had been planted, again, in the wake of a real potential degradation and introduction of excess pollution to this community, were then going to be taken out in order to widen the roadway. And thankfully, the city of Boston ended up seeing it the same way. Anyway, I could go on, but I just wanted to sum up by saying I think it's really, really important that government thinks about how it can work to translate stuff coming out of the academy into something that's really going to get things done in politics, both at the legislative and regulatory level, and also at the grassroots and community levels. And also in reverse, government can be a conduit from grassroots community groups to the academy and to legislators and regulators. And I think we need to be prepared to think outside the box and work in some non-traditional ways, right? Both of the things I talked about were not litigation, to attack some of these problems we're seeing. Thank you, Britta.
David, thank you so much. That is exactly the kind of connection between academics and NGOs and politics that we hope that a conference like this is going to foster. And you've already been doing it. And I have to thank you so much for your strong advocacy about Melnia Cass. GBPSR was also a very active public health voice on that issue. And also your advocacy around COVID-19 and air pollution. And I too benefited from that database that you put together with John Levy at BU for some of an article I was writing. So thank you for all of that work. I would now like to move ahead and introduce Leslie Melendez. Leslie Melendez is Deputy Director at Groundwork Lawrence, where she's been instrumental in expanding the community-based programming.
Right, on the schedule, we had Marianne Sargent's video first. Did you want to skip over that?
Yep.
Or
We're going to go to Leslie if she's there.
Yeah, she's here.
Yep. She has been instrumental in expanding the community-based programming. As a lifelong resident of Lawrence, Leslie has always been passionate about serving her community. Thank you, Leslie.
Thank you so much, Britta. And thank you to all of the presenters that have presented so far. And David, the work that you all are doing at the AG's office is just phenomenal. So thank you, everyone. Again, my name is Leslie Melendez, and I am the Deputy Director at Groundwork Lawrence. Groundwork Lawrence has been around for about 21 years, but we do have sister agencies across the United States, with 3 of those being here in Massachusetts. So it's Groundwork Lawrence, Groundwork Somerville, and Groundwork South Coast in the Fall River, New Bedford area. So a little bit about Lawrence, and a special shout out to Dr. Farber for mentioning some of the stuff that was happening in Lawrence in years past. I'll talk about a little bit about that as we move forward, but a little bit about Lawrence. We're about 25 miles north of Boston. It is a very small community, 7 square miles, with potentially, this number says 80, but we do know that it's probably closer to the 90s. There are 3 rivers running through it, with about 45 parks and 3 grocery stores in the city itself. So I wanted to talk a little bit about what brownfields and air pollution and ground pollution caused in Lawrence. So this is a photo of a 2.7 acre site that was contaminated. There was an industrial dye factory here at one point in the 70s that closed down because of the fire that happened there, and then its subsequent ownership through banks. The space kind of stayed this way, and it is actually in one of the densest neighborhoods in the city of Lawrence. So for years and years, Groundwork worked with the bank that owned it then, and the city of Lawrence to kind of come together and figure out how this was going to change, how we were going to maximize not just the space itself, but to make it a safe space for the residents in that neighborhood. The neighbors got together and really started talking about who do we need to pull in, who do we need to talk to get this space cleaned up, to make this a safe space for our children. Because in Lawrence, as I said earlier, it's only 7 square miles. It's completely built up, so you've got very little open space. Most of our parks are very small. So through a community process, we were able to sit in folks' living room, having coffee with a landscape architect, and work out what this would look like. And this is what the park looks like today. We were able to take this vacant space, get it remediated, and we're able to make it into a usable space, right, for the neighborhood. And not only did it increase the cohesiveness of the neighborhood, but it also gave them the opportunity to have this green space, which is so important, as we have heard in many of the conversations today, is so important around health, both physical health and mental health. So Groundwork Lawrence has been really part of our beginnings was around taking these brownfield spaces and converting them into spaces that were usable by residents of the city of Lawrence. But all of this is done through a community mandate, right? All of the work that we are doing because we are being asked by residents to intervene, to look at and talk about what these interventions are like, what people can do, and what they can achieve if they dare to dream. One of the other parts of our programming is our tree planting program. And I'm so happy that many of the presenters talked about the importance of increasing the tree canopy. So in Lawrence, we, again, back to this 7 square mile built up space, tree canopy is there's a beautiful tree canopy in some of the more residential neighborhoods, but as you get into the more dense neighborhoods, you have very, very little green space and very, very little tree canopy. So in partnership with the state of Massachusetts, we launched, or we're part of the Greening the Gateway Cities program, which is taking, over the past 3.5 years, planting 2,800 trees in a 500 square foot, in 500 acres, to make sure that we are increasing that canopy. And one of the things that we talk to residents about, because there's a, being in a immigrant city, there's not quite the same understanding of the importance of these trees and the green spaces. But there is this education that happens, right? There is talking to folks about why it's so important. There's talking to folks about not just it's important for the air, but it's also important for your heating and cooling costs. It's important for your mental health, and making sure that folks have access to all of these things. So just a little bit of background on some of the things that cause such deep and hurtful things that happened here in Lawrence. Dr. Farber mentioned that there were 4 incinerators within 12 square miles. 2 of those were actually in the city of Lawrence itself. Again, we're back to 7 square miles, and you've got 2 incinerators in the city of Lawrence, one of which burned close to 700 tons of trash per day. And through community involvement and through the need and the understanding of what that was causing to one of the other most densest neighborhoods of the community, folks got together and said, hey, this can't happen. And today it's a beautiful park. And it is the crowning jewel of what we like to call the Spigot River Greenway, which is another way for folks to transect the northern part of the city. But that wouldn't have happened had there not been community involvement, had there not been residents who decided that enough was enough, and that we were suffering disproportionately to our neighbors, right? And someone said earlier today that it's not about spreading out the air pollution, but about doing equitable work around it. And I 100% agree. But there's also this need to make sure that communities of color that have been affected disproportionately by these things have a voice at the table. And that's what Groundwork does. We work towards making sure that we have this voice at the table, that we as an organization are giving the residents of the city of Lawrence all of the education and all of the tools that they may need to take these efforts up. So as part of that, this evolution of this park system happened in Lawrence, and 45 parks might seem like a lot to some folks, but it actually is not. 2 parks are in the 17 acres. The rest of the parks in Lawrence are very small parks. They're pocket parks in neighborhoods and communities that give the opportunity for folks to have a cool space, give the opportunity for folks to have an urban garden. Lawrence is built on urban fill, so you can't really garden in your backyard, but being able to create community gardens across the city, we have 10 of them. There is this now opportunity for folks to continue being able to feed their families in a way that they were feeding their families back on the islands where they come from, because generally the majority of the folks in Lawrence are from the Caribbean. So again, part of this is, how are we transforming Lawrence to be a greener, safer city for all? And I'm happy to share these slides with folks afterwards. Just feel free to shoot me an email. But again, back to the Greening the Gateway Cities program, we have a program called the Green Streets, which is how we're doing some of the work in terms of increasing our tree canopy. Community engagement and partnership, that at the end of the day, that is how we are able to get this work done. Partnering with local businesses, partnering with the municipality, partnering with our state and federal partners and delegation, but more importantly, partnering with our residents to be able to do what they are seeing needs to be done in the community. We have a task force under the Resilient Corridors program that we have. It's a group of city residents who are working together to identify corridors and routes to create cooling strategies in the city. We have deployed air quality monitors throughout the city, and are partnering now with DEP to deploy another 20, I believe, of purple air monitors to be able to see some of this. As part of that, we're working towards gathering some funding to be able to do some of the dashboards that some of the presenters have spoken about today. And to tie it all together, you know, we do a lot of this work in partnership with our youth, because having the youth voice at the table is one of the things that is at the core of what we do. We have to make sure that we're incorporating their voices, that we are incorporating who they are, because as we transition to the next stage of our lives, they're the ones that are going to be taking up this mantle, and they're the ones that are going to be doing this work as we move forward. Just a little bit of what the impact has been in the city and our annual program impact. You know, we are growing food, we are planting trees, we are working with community to give them the voice that they wouldn't necessarily have at other points. So again, thank you so much for having me. Thank you so much for just allowing me the space to voice the side of the community on some of these very important issues. It's great to be here. And that is my email address. So if you need to contact me, please, by all means do. Thank you.
Leslie, thank you so much for that inspiring talk. It is so fantastic to see what's going on in the community, to put together all this data with what we can do with that data to change lives, right? Thank you again. So our next speaker will be Latifa Ziad. Latifa currently serves as the Resiliency Planning Coordinator at the Neighborhood of Affordable Housing, or NOAA.
Our in-person farmers market from July 1st to about.
Hi, welcome everybody. I'm Latifa Ziad. I am the Resilience Planning Coordinator here at the Neighborhood of Affordable Housing, and we call it short for NOAA. And NOAA has been around for about 35 years doing mostly affordable housing work, but looking at a whole lot of different spinoffs to come out of that. So we've been doing rental relief. We've just reached $11 million of rental relief, particularly for this year because of COVID. And we do a lot of work in the community. We've given out food during COVID, up to 200,000 pounds. And so we bend with the times a little bit, but we are anchored by our affordable housing work in that way. So NOAA is housed in East Boston, and in East Boston, I'm trying to move my slide and it's not moving. Can you help me?
Well, I can just bring it up on my end here. So here, just tell me when you want the next slide and I'll.
Okay, so East Boston is predominantly a Hispanic community where 50% of the people are foreign born. It is the largest Hispanic community in Boston. Next slide, please. We at NOAA wrote a grant to the city of Boston, their Air Pollution Control Commission. And what's interesting is first we wrote the grant and we were not awarded in the first pool of rounds, but we wrote it a second time after getting feedback from them. And then we became the only recipient in the second pool of rounds. So we tweaked some of the things that were shared with us and were able to mute. And I'm sharing all this to kind of show you how kind of like what happens when you try to invest in a new space, but is germane to the work, of course. So our grant had a basic framework of looking at 40 businesses, schools and residential and nonprofit spaces in their common areas. And basically the essential outline of the grant is that we would have 10 businesses in their public spaces and 30 residential areas. And we picked the residential areas because East Boston is divided into kind of 4 quadrants. And in those 4 quadrants, Eagle Hill, Orient Heights, Jeffreys Point, those segments, they're all kind of around the periphery of the airport. And so we looked at wind patterns, and we looked at the airplane patterns for takeoff and landoff to figure out what households might be more or less affected. And so as a result of that, we ended up getting 30 families on this list, looking at a wide swath from them being mostly disproportionately Hispanic, but adding in and making sure that there was a good span for socioeconomic, and that almost 50% of them had asthma that we were looking at. Next slide, please. So as part of our program, just kind of raise awareness, we gave each of these families and businesses a plant. And the plant was basically to let you know that in order for you to have the same results of a HEPA filter in your home, if you had a 500 square foot apartment, you would need 5,000 of these plants. So we wanted to make people aware that plants were not enough, and you could not possibly have enough plants without making your home a forest to have some of the same effects as of this. But we were also able to share with them some of the plants that are known for air quality to be improving. Next slide, please. So what we looked at, and this is a new project for NOAA, we've never done something quite like this before. So what we did in response to the grant is we went in with an organization out of New York that was known for doing this work. And their role was to basically do the workshops to help our participants understand the process. And the process was for 1 week, we would put a sensor into their homes. And this sensor is to pick up PM1, PM 2.5, and PM10, and look at what would happen if we added an intervention of the HEPA filter for the last week. So basically, we were looking at pre and post HEPA filter intervention, and we combined this with having one of our sensors outside, so that in close proximity to one of the sites, so that you could see what the difference is between what's going on right outside of those apartments and what's going on inside the apartment simultaneously. So in part of this process, in order to communicate that out, we created a newsletter called Beastie Air Weekly, where we shoot off this information to participants through a barcode system, where they can kind of see what's happening in their unit, and for the general public to be able to also follow along with this. So what we did is we shared with them how particulate matter affects them. So we let them know that the 10 micrometer diameter particles could get into their bloodstream, that this could affect their lungs and their hearts, and that different coronary artery diseases that were connected to intake of particles, including asthma, and how it affected particularly young adults and children and exposure. Next slide, please. And then we share with them what they would typically experience: eye, nose, throat irritation on the lower end, and then aggravated coronary respiratory disease as a scale upward, and then how it may influence levels of death also from this. Please, next slide. In order to make it clear, like the diameter difference between this, we looked at a grain of sand, which is to your far left on this screen, and let them know what that looked like in comparison to a human hair, which is approximately 50 to 70 micrograms, and then looked at PM10, which was less than or equal to 10 micrograms, and then PM 2.5, which was less than or equal to 2.5, and then the ultrafines of 0.1 micrograms. Next slide, please. So what we ended up doing is we didn't end up working with the regional company out of New York, because what we realized in doing this work is that really politics are local, and we wanted to tie into a company that had other nodes throughout areas that are adjacent to East Boston, so it wouldn't be a one-off experiment, but we could connect in with things that were happening in Chelsea, in Revere, and in Roxbury. So we switched gears and went with QuantAQ, who helped us with their modular air PM, look at PM1, PM2.5, and PM10. And they put the system sensors that we had previously only went up to 2.5. So this was an effort to kind of dig deeper as well with this type of sensor, which costs a little bit more than we had initially put out. But the City of Boston, through the Air Pollution Control Commission, did go ahead and help us by adding funding in to support us as a partner when we did have cost increases. Next slide, please. So we ended up using Austin air filters for this project, which is the Cadillac air filters. These are air filters that are $700 on the market, but through collaborative networks, we were able to reduce that price down to half. So collaboration is key. Next slide. We share with them the index level. So it doesn't mean anything to anyone to learn what a microgram is unless they have some context to it. So we shared that this graph with those folks to know, like, where do you fall? Next slide, please. So here is the long-awaited graph that we have. This is just from one of our node sensors in the Eagle Hill area. And you can see where the peaks are connected with their cooking times, basically. And where the lows are connected with sleep times. So you can see from the red and the green, those are actual measurements of what has happened through combustion, and the gray are what is happening when people are awake kicking things around. Next slide, please. So we looked at it from Suffolk and Middlesex, and you can see that in Suffolk, there are only 6 days outside that the EPA are saying we're in the warning zone areas. So we asked our engineers, why is that? And they said, because the measurements that they're using are in the 24-hour cycle. So any one incident, like from a plane, would just be absorbed into that average. So you're not really getting what's happening on a point by point as these planes are flying over in sections. Next slide, please. So our findings basically conclude: research early so you know what kind of partners you really need to have, collaborate so you could stretch your dollars farther and use their bandwidth of history. We also partner with Air Inc. now to kind of get the history of what they've been doing over the course of many years. Build in cultural norms, because what we found out was through conversation and in the Hispanic community, there were certain spaces that it wasn't clear. For instance, the Austin air filters were large, and some of them wanted smaller ones for their apartment, which didn't have the same impact. And then reevaluate and reform your project as you go along, because it's a learning curve. Thank you.
Latifa, thank you so much. What an amazing amount of work that you have done in a completely new area for NOAA. So, so impressive. I would not like to next introduce our next speaker, Dr. Gaurav Basu. He is a physician and founding co-director of the Center for Health Equity, Education, and Advocacy, CHEA, and an instructor at Harvard Medical School's Department of Global Health and Social Medicine. Thank you, Dr. Basu.
Thank you so much for having me, everyone, and thank you for this this great day that GBPSR is putting on together. So grateful to be with you all. So yeah, my name is Gaurav Basu. I'm a primary care physician, and a lot of my work is in health equity, medical education. That's kind of where I came into climate work. Next slide. You know, we're living in these extraordinary times, and we are facing many dueling threats, and it can be quite overwhelming. My 5-year-old is behind us, and I is one of the reasons why I'm doing this work. But he's playing with some trains. We're living these extraordinary times, and it can be really overwhelming. We're coming off the heels of this IPCC report earlier this week, and my takeaway from that report is that we have everything we need to move forward. And of course, we're trying to decrease these emissions. But what's really wonderful about this air pollution frame is that the benefits to our health and our health equity are immediate in being able to get off of fossil fuels. Next slide. So, speak to this again, is that I think when we see the particulate matter coming from the wildfires raging and know the impacts on our children's health, we've got to really make the connections between understanding the ways in which that's interfacing with the crises of COVID and structural racism. And that's a lot of what I try to do in my work, is to try to really connect these dots of these broader structural forces. Next. So Dr. Kamara Jones's work has been very influential in my work, and she's been a real pioneer in defining structural racism in health and healthcare. And she defines racism as a system of structuring opportunity and assigning value based on the social interpretation of how one works, such that it unfairly disadvantages some individuals and communities, and unfairly advantages other individuals and communities, and saps the strength of the whole of society through the waste of human resources. Every time I read this definition, I really recognize the ways in which this is connected to our issues of air pollution and health equity. I think that is exactly what we're doing as we burn fossil fuels. And for me, this definition puts really the direct connections between the burning of fossil fuels and structural racism. Next slide. This was let me be a little more concrete about it. So this was a friend of mine who I went to college with, actually, back in the day, did this major study that came out recently that showed that the racist policy of redlining that existed from 1934 to 1968, pulling away resources from communities for a long period of time, it can be directly connected to 45 million Americans breathing dirtier air, even 50 years after this policy ended. Next slide. Okay. All right, my buddy's going to help me here. He's going to join our conference here. Say hi. Here's another way in which structural racism plays out in the in how the exposure of air pollution plays out. We've got to look at transportation policy and understand that the ways in which we have created a transportation system where we put the overpasses in which communities not only transects these vibrant communities and breaks up the civic space, the open space of these communities, but in addition, it has disproportionately put the impacts of air pollution on communities of color. Here we see that very much locally here, there's important conversations happening in Detroit, in Louisiana, in Houston, about the ways in which we wouldn't be putting these overpasses in these highways in certain communities, but we are doing it in another place. Next slide. And I want to put a real anchor here on the global implications. So this was, many of you have seen this study. It was a major study that came out a couple of years ago, showing that in 2018, we can now feel confident that millions, even up to 9 million people, 1 out of 5 premature deaths occurred because of the air pollution connected to the burning of fossil fuels. This is extraordinary, an extraordinary number. It's hard to get our head around, but at the same time offers us some clarity of how much impact we can have once we get to a clean energy system. Next slide. And I just want to make another point. I think when we start getting into these intersecting crises, we see the ways in that wildfire smoke, how much that has increased. The exposure to fine particulates from wildfire smoke has been shown to be dramatically, even 10 times more harmful to pediatric respiratory disease than other forms of air pollution. Next. And I just put a local slide in here from the state of Massachusetts showing, in real time here, how a disproportionate exposure to transportation-related air pollution is impacting our communities. Next. And just one final word about the impacts. I think people like Brady Seals has done extraordinary work. Andy has been such a big part of this work and real inspirations for me of showing the ways in which air pollution within the homes, and again, with a major equity implication here, are causing so much harm within our homes as well. Next slide. So this is hard, and we all, all of us here in this conference don't need to be told that how overwhelming and big this problem is. We also need to have a vision for the future. And we can be changing the ways in which we do energy and transportation, the way we build our homes. Obviously, this intersects the issues of air pollution, intersect directly with greenhouse gas emissions as well. And again, looking at the IPCC report from this week, my takeaway, the only takeaway I need, is that we have everything we need to move forward. And I get really excited picturing this world in which we have gotten rid of these pollutants, we have stabilized our planet, we've cleaned our air and water, and we're allowing people to thrive. And I think it's important for us to put forth that positive vision of what we can do. Next. So these are just questions that I offer to you as we're closing up today, is what systems do you want to change? What communities do you want to be a part of? Where do you find your strength, your inspiration, your power? What roles can you be most effective in? What issues do you want to spotlight? And what world do you want to make and why? Next slide. And, just another point that health professionals, you all don't need to know to be reiterated on this, but we are such a trusted voice in this. We have the value of being storytellers and making this problem very human, and explaining to people in very human impacts of the ways in which these confusing issues of air pollution and climate change can be. Next. I think that it's extraordinary to see the ways that attitudes are changing. Of course, public discourse is hard. We all know that. Science denial is real. But, I think Catherine Hayhoe is an inspiration for me, who tells me that, listen, we've got a governing majority of people who care about this. The number of people who are increasingly alarmed and worried about these issues is growing significantly. It's a political issue. And something that people are demanding in a way that they never have before. And that is having impact, although we never feel like it's fast enough. Next, please. And so this is a slide on emissions, and I do admit it's emissions and not air pollution, but I offer it for the fact of that this is where US greenhouse gas emissions are today. And it tracks, this graph tracks where our goals are to decrease our emissions by 50% in 2050, which obviously will have a great impact on air pollution. When I see this graph, I remember Dr. King's word that the arc of the moral universe is long, but it bends towards justice. I know the news is really hard and bad, and this is super scary. And this little kiddo on my lap here, I have sleepless nights here thinking about our children's future. And we're on this together, and the worry that we share, we do together. I look at this graph, and there's no one who can tell me that we cannot do this together. For all the mistakes, for all the false starts, for all the ways we've done it wrong throughout our history. And of course, it's never going to be enough. But I look at this graph, I look at the policymakers and the communities, this one being one of them, that are working with all their heart to end the era of fossil fuels. And I'm certain that we have a path forward. It's not going to be easy. It's going to be a heck of a lot of work. And it's going to take us health professionals being at the forefront of really putting the human face of this, putting equity and justice and structural racism at the front of this conversation. And again, allowing us to have extraordinary imagination of what this world can look like. We've had these converging crises that have overwhelmed us. And it's a real reckoning on how we move forward. And so it really challenges, it challenges us to do the deep work, to understand the roots of these problems, whether it be structural racism, whether it be COVID, whether it be our reliance on fossil fuels from places like Russia, or the climate crisis and the air pollution that's related to it. I believe that if we get to that deeper level of transformation, we could be solving a lot of problems at once. And I'm grateful to do that work with all of you. Thank you.
Thank you so much, Dr. Basu. We are now going to move to the section of our last panel, our question and answer section. And I would like to start, because Dr. Basu has to leave for another talk that he's giving in 10 minutes or so, I will start with him. So Dr. Basu, how can we as clinicians be better partners to community initiatives?
Yeah, I think that is really an important thing. And as much as I talk about structural racism and health equity, I think community partnership is inextricably tied to that. And the truth is that health professionals have not done the best job of that. We've been trained in a way in which our training is within the hospitals, it's disconnected from communities. And the fellowship that we're running right now is a community organizing fellowship. That's what's starting at 12 o'clock, is to I want to say this with precision. We all feel urgency, right, to get these policies right and to move ambitiously forward. But we've got to do the work of building the relationships with our community. And that's messy work that is slowing down sometimes, that's building trust, that develops a long period of time. And so I'm not saying that we shouldn't feel urgency. But again, I am really focused on this dimension of depth, that we have to build deep, trusting, caring relationships with our community. And I think it starts with understanding the ways in which we haven't done that well as health professionals and building true relationships with organizations that have been doing this work for decades. I think the nexus of that partnership is very exciting, but we're going to have to work against some of the tendencies that we were taught in our training.
Absolutely. Thank you for that. Leslie and Latifa, do you have any key takeaways from your programs in East Boston and Lawrence for advocates who are trying to start similar initiatives in their communities?
Absolutely. And it's echoing what Dr. Basu is saying. It's relationships, it's collaborations. We cannot do this work in a silo. We have to work with our partners. We have to work with healthcare. We have to work with municipal leaders, federal and state delegations. Everyone has to have a part of this work because we cannot do it alone. There has to be that enforcement arm. There has to be that healthcare conversation happening. We partner with our health center here on a variety of projects, from mobile markets to community gardens. We're very involved with the hospitals here. We're part of their community needs assessment work. So it's all about the relationships. It's all about those collaborations. Without that, this work is not going to move forward in the way that we want it to.
Latifa.
I agree wholeheartedly with both Leslie and Dr. Basu in that it's critical to the work. And we found that out, in other projects, but in this particularly, as it's a new space, it is, I can't even stress it enough, not enough exclamation points. Not only were we able to vet in real time on the Bell alcohol that you are part of, Rita, but also and get feedback in real time as to different precautions and different things to look for that we wouldn't have had the bandwidth to even pinpoint without those conversations. But by collaborating on the ground with some organizational partners, we were able to double our budget by getting a 50% decrease by people who are doing this more often with vendors, and kind of piggyback off of that and get new direction on letting go one partner for another based on components that would give us longer life and more use in our own personal universe. So it was everything to have collaboration in doing this work.
A quick follow-up question from the audience. Dr. Susan Racine asks Latifa, do you have any information regarding the PM 2.5 in the home compared to the PM 2.5 outside homes in East Boston yet?
Yeah, so one of the things that we discovered in this is that the levels that were in the home were higher by far. And that's because when people are turning on the gas stoves, they're not venting those systems. So you see those different spikes that were there, whereas the sensor outside was not getting any of that because there's so much air moving around. So we find that telling people that they need to open up their windows, vent, and get these HEPA filters is critical if you're going to use these gas stoves, and try to figure out longer term, like Dr. Basu was saying, how do we build homes that are preventing this from occurring. So yes, we're looking at the airplanes, but on the ground, we have a whole different kind of fight.
So there's a huge question to Dr. Basu. How often when you see your patients in clinic, do you mention the risks of gas stoves, the risks of indoor air pollution, and how they have to open their windows to ventilate, especially if it's a patient with pediatric asthma or adult asthma?
Yeah, I mean the percentage, you see 25 to 40% increased chance of childhood asthma because with gas stoves. I mean, listen, I think my patients are my greatest teachers, that they're the ones who give us the anchor of this moral work. And the thing about these crises is you put a lens on it and you see it everywhere, right? Once you see it, you can't unsee it. And so it is, I will tell you that there is no regular practice. There's no system in place for those kind of screenings. I do it in my own ad hoc ways. The truth is it's not systematic and it needs to be. And that we need to be knowing what zip code our patients are living with. We should understand generally what the air pollution levels are at all times. We're working with the students. The students have been leading the charge in teaching, like getting this into education and the way we do it. But the honest truth is we've got a long way to go to operationalize that in clinical care.
Thank you. David Wittenberg, not to leave you out. So David, what do you see as the biggest barriers to enforcement of our environmental policies? And in particular, how will the new roadmap law that stipulates taking into account cumulative sources of air pollution, how are we going to go about enforcing that?
So the enforcement mechanisms are imperfect, right? And changing them is not easy. I think that the enforcement mechanisms that exist are really about source pollution, are about so within state law in Massachusetts, and it's analogous to federal law, it's releases into the ambient air, right? There's certain dumping that's characterized as solid waste violations, and there's certain types of dumping that's characterized as more of a toxic waste violation, and then wetlands, and then there's a huge and far more punitive, and I think this is really illustrative. There's a far more punitive regime within the environmental law having to do with marine fisheries and protecting the shellfish from contamination and shellfish beds and all of this stuff, and both the sentences and the civil penalties that you can get around shellfish. I'm not saying that's not important, but are far greater than you can get in cases having to do with clean water and clean air. So it's something that could and should be revisited. I think one difficulty is how do you revisit it in a way that takes into account the systemic inequities within the justice system in terms of who ends up being prosecuted. Certainly, in my cases, the defendants are really wealthy people with huge businesses, but it's not it's correct to have the concern that increasing an enforcement regime could have a disproportionate effect on poor people and people of color. So it's sort of sticky. But I think that looking at new mechanisms is certainly helpful. The other thing is that a lot of it hasn't really been tested, right? So for example, I won't say chapter and verse, but there's a law, that has to do with, creating a risk of harm to public health through, for example, dumping or a release. For those who know about it, 21L. And I can't think of a recent prosecution under 21L. And whenever we think about charging under it or doing a civil complaint under it, it's well, how is this going to be considered in the courts? I think you have to remember also, we've talked about translating between the medical community and the grassroots community and vice versa. When you get into a legal setting, these judges are people who may be seeing cases about business law or embezzlement or whatever, and in their personal life may be really into golf and the Patriots. They just don't think about this stuff. So we have to think about how to educate the courts Even though, sure, these laws are on the books, but when we go into the court, how do we educate the courts
Right.
on this stuff and the importance of it?
So a follow-up comment and a question. So one thing that's really struck me about Attorney General Maura Healey and really impressed me, for example, was her approach to gun control. And she said, she didn't actually go and change any laws. She just enforced the laws on automatic weapons, for example, that were already there. And people acted all shocked. But she was like, those laws were on the books. I just enforced them and they hadn't been enforced before. So I guess the question is, could we not do that with environmental laws? And my follow-up question is, Leslie mentioned earlier that there was a school that was built right on top of a landfill in Lawrence, which to me is an environmental crime. So I would like your definition, since you run the Environmental Crimes Unit, what is actually the definition of an environmental crime?
Yeah, so to be clear, I'm an assistant AG in the Environmental Crimes Unit. My chief is Dave Clayton, who's a phenomenal attorney and advocate. Let me try to take your questions in order. So the definition of the environmental crime, but then can you remind me the first one briefly, Britta? I'm sorry.
That was really it. That was it. Just what's
okay. No, I remember your comment about using the existing enforcement regime in creative ways is really well taken, and it's something we're trying to do. I think, like, for example, with the case that we indicted last week in Lowell and Fitchburg, where there were 106 counts under the Clean Air Act. And I was told after doing that, this isn't something that we've seen before, having something that's, purely environmental violations. Usually we're trying to find something else. So yes, I think more aggressive enforcement of stuff that's on the books, and it's something that we have done, frankly, since in civil court, since starting our asbestos initiative in particular in 2013, has been, this really interesting regime of increased enforcement and using that to change practice on the ground. But I think over the next 12 months or so, you're going to be seeing more of that in more environmental justice communities around the Commonwealth. In terms of so the Environmental Crimes Strike Force, as such, was started under the Dukakis administration, and it's this interdisciplinary approach where we collaborate with partners in the environmental police and in DEP, which has its own strike force unit that was specifically created to liaise with us and investigate on our behalf to look at environmental crimes. Why would something go criminal instead of civil? So most of these are deriving from the same statutes, right? So if it's under the Clean Air Act, for example, there's a civil option or a criminal option. Usually you're talking about the scale, the vulnerability of those affected, whether there's some kind of lying, cheating, or stealing that was involved, all of these things, and then sort of the impact of the release, right? All these things would push us more in the direction of a criminal investigation.
Thank you. Thank you so much. Dr. Basu, I know you need to log off for your next talk. Thank you so much for joining us today. I have just a couple more questions for our speakers, and then we will be doing our last talk of the day, which we delayed just so that we could have you here for our live Q&A. Thank you so much again.
Thanks, everyone.
So Leslie and Latifa, a question for you. So of the different environmentally focused initiatives that your organizations have spearheaded, which ones do you feel have had the greatest impact?
Wow, that's a good one. I would say that our work around food security and shade equity are two of the things that we've done that have had the most impact in the community. Like I said earlier, we have 10 community gardens within the city, and that was in direct response to individuals coming from the islands wanting to grow their own food and not being able to because the soil in Lawrence is so contaminated. So giving them those spaces. And then in terms of shade equity, planting 2,800 trees over the course of 3 years has significantly improved the air quality in some of the densest neighborhoods in the city. And continuing that work, we have, secured some funding to continue that work and to do some more of that work in some of the neighboring areas of Lawrence. So in Methuen, where the Arlington neighborhood kind of goes from Lawrence to Methuen, it doesn't stop. One of the things that we are very mindful of is that these issues don't have municipal boundaries. We have to work together, community by community, to be able to address these issues on that larger scale.
Right, well said. Latifa, anything to add to that?
Yeah, I would say we've been around for a long time, 35 years, and so we've dealt with everything from the salt mounds that are on the edge of Chelsea to environmental justice work around. We got a Kresge grant to do summits, climate resilience summits, where we were able to bring together over 300 residents practitioners to have these conversations that are deep. We've done at least 3 of those summits so far, and we're working on our 4th. We're building the Resiliency Network, which is going to help families bounce back, plan forward, and recover from all kinds of disasters. We're also in the food security and security work, and we've anchored that through climate as well, doing a 6-part concert series up and coming over the next 6 months. So we've just been able to naturally interweave a lot of our work. We did working with NYU. We went door to door to 270 households to figure out what they're dealing with climate resilience as well.
Fabulous. Well, thank you so much to all 3 of you. It has been so wonderful having you. Just to the audience, I'd like to let you know there's one more talk. I delayed the talk because we wanted to get Dr. Basu in here before he had to leave. So thank you again for joining us today, and we will turn to Dr. Marianne Sargent's talk. And just to introduce her piece, Marianne Sargent is a research scientist. I think I promoted her by calling her doctor, at the School of Engineering and Applied Sciences at Harvard University, whose research focuses on using atmospheric measurements of greenhouse gases to quantify their emissions. Dr. Sargent.
Hi, so thank you for having me today. I'm going to be talking about how to improve U.S. urban natural gas emissions inventories. In particular, I'll be focusing on a study that I did here in Boston, where we used atmospheric measurements of methane to calculate the emissions from the urban area. So why are these atmospheric measurements important? The majority of greenhouse emissions actually come from urban areas. And in the US particular, cities and states have really been taking a lead in efforts to reduce emissions. Boston in particular has a goal to be carbon neutral by 2050. So in order to achieve these climate goals, governments need methods to monitor emissions and see if policies are having their intended impact. However, methane emissions can be really difficult to monitor. The typical method that governments use to monitor emissions is what we call a bottom-up inventory. So in this case, they add up the emissions, from each part of the supply chain. So you measure a bunch of pipes, see how much they leak, and then multiply that average by the number of pipes in the system. Same for compressor stations, appliances in your home, well pads, etc. But what's tricky about this is that methane can escape at so many different points along the supply chain that it's really easy to miss some of them. On the other hand, for CO2 emissions, it's pretty easy to do these inventories. So you burn a gallon of oil, it's, the CO2 is emitted right where it's burned, and you have a pretty good sense of the conversion factor in terms of how much, CO2 is emitted per gallon. Whereas methane, you have this long supply chain, and any emissions along that supply chain are going to have a strong greenhouse impact. So these bottom-up inventories, they can miss different sectors, and they also have a hard time accounting for what we call super emitters. So in most sectors, you tend to get more than half of your emissions coming from the 10 to 20% of emitters that are the worst. So typically when there's some sort of a problem with the equipment. So if your study, your sample that you do the measurements on doesn't have as many of these super emitters as is statistically found across the country, you're going to miss a lot of emissions. So for all these reasons, these bottom-up inventories have a hard time finding all the methane emissions. So we turn to the atmosphere because the atmosphere is going to aggregate all of the emissions from the area, and you can't miss things in the way that you can from these bottom-up methods. So here's a look at some of the equipment that we used for this study. Here is a Picaro spectrometer. So this is a laser spectrometer that measures methane based on the absorption lines. And we have them on the roof of 2 buildings in Boston, and then 3 towers, typically like cell phone towers outside of the city. So this just shows kind of some of our inlets on top of the buildings where we're measuring methane. This shows where our instruments are. We have 2 in downtown Boston on a building at Boston University and 1 in Copley Square. And then we have 3 outside the city. So this black circle defines our study area, and the key metric we're going to be looking at is the change in methane concentration as the air travels from the edge of this circle into Boston. So how much is methane increased in the atmosphere based on all the emissions in this region? So just wanted to give you a really brief overview of the model that we use in this work. So in the model, we take air parcels that we measure in Boston, and we follow them backwards in time based on winds and turbulence from meteorological data. And every time they interact with the surface, they'll get inputted some of the emissions. So this model produces what we call a footprint. So this kind of shows which areas are adding to the methane that we measured in Boston on this particular day. So what we do here is we have our change in methane that we observe in the atmosphere, so our urban site minus our background site, and we compare that to what we get from the model. So the model just takes the emissions inventory, which is, grams emitted per meter squared per second in each, part of the city, and the model converts that into an increase in methane in the atmosphere. So we compare what we get for an increase in methane due to our prior estimate to what we actually observed. And then we adjust our inventory to better match the observations. So how high does this inventory need to be to actually explain the methane that we observed in the atmosphere? So that's how we calculate what we call our optimized emissions, or our best guess of the emissions based on the atmospheric data. Another component of our model is that we also measure ethane. So ethane is emitted with methane that comes from the natural gas system. So here's a map of the different pipelines serving the region, and they all report the ethane to methane ratio that's coming in on the pipelines. In contrast, methane coming from biological sources such as wetlands, landfills, sewage, that's not going to be associated with any emitted ethane. So by comparing the ethane to methane ratio from the pipelines to that which we actually measure in the atmosphere, we're able to determine how much of the methane that we're seeing was natural gas in origin. And what we find in the winter is it's actually almost all coming from natural gas. So here's a look at some of the results from this study. So I'm showing here the natural gas loss rate. So the percent of all the gas that's consumed in the area, which ends up being emitted to the atmosphere. So in red here, I'm showing the estimate from a Massachusetts inventory that was released in 2013. In black, I'm showing a 2018 inventory. And then in orange, this is the inventory I put together for this paper, which is kind of the best estimate based on the latest research, which is just a little more current than what was included in the past Massachusetts inventory. So you'll see, some of the uncertainty in these bottom-up methods, they've changed by quite a bit with these different assessments. But then you see up here, these are the different top-down estimates based on the atmosphere. So green is a study that was published in 2015 based on the same network. And then data from this work with just 2 different wind models is shown in blue and pink. So a couple things stand out here. First of all is that these top-down estimates are about 3 times higher than our best estimate from the bottom up, and about 6 times higher than the numbers that the state is currently using. So this is a big gap in emissions that's really unexplained, and that is the state isn't really accounting for when they're doing their greenhouse gas tallies. And the other thing that stands out is that there's really no change in emissions within the uncertainty of the model during this time period. And I'll talk in a minute about some efforts the state has made in the past during this time to try to reduce methane emissions. So we're not seeing any impact of those efforts over these 8 years from 2012 to 2020. So in 2014 and 2018, there were laws that went into place in Massachusetts that were requiring gas companies to repair leaks of certain sizes in a timely manner. And they also required them to report the number of leaks on their system. So I'm showing here the left in the filled in circles is the total leaks on the natural gas system of different sizes in each year. So you can see when this 2018 law went into effect, there's really no change in the total leaks, or to the right here in the number of repairs that they're doing per year. So what this shows is it pretty much confirms what we're seeing in the atmosphere, which is the gas companies are kind of playing whack-a-mole. So as soon as leaks show up, as soon as they repair leaks, more leaks are popping up every year. There's also been some efforts to replace old pipeline. So, when you have a leak, there's two choices. You can repair the leak, or you can take out an entire stretch of pipe and replace it. And replacing pipe is a lot more expensive than just repairing leaks. But there was thought that, well, if you repair a lot of pipe, if you replace the pipes, you can stop future leaks. But unfortunately, what we've seen is despite a lot of money that's been invested in replacing pipes, they've only managed to replace 8% of the leak-prone pipe since 2012. And it has not yet made a dent in terms of reducing the leaks that seem to spring up every year. So we're starting to realize that we're kind of throwing good money after bad in terms of this pipeline replacement program. And, it's not having an impact yet in terms of the emissions, and maybe we would be better off spending that money towards moving away from natural gas rather than burying that money in the ground and extending the life of our natural gas infrastructure. So I wanted to compare our results in Massachusetts to some other studies that have been done around the country. So I'm showing here in gray are some bottom-up inventories from these different cities. And then the colors are different types of top-down atmospheric measurement-based studies that have been done in these cities. So what you see is that in every study, the top-down emissions are significantly higher than the bottom-up, ranging from 2 to 10 times higher. So there's really something consistent where these bottom-up inventories are missing a huge chunk of the emissions. And these studies use a lot of different methodologies. They're carried out by different groups from different kinds of platforms. Some are from aircraft, some are from tower. So this is really consistent across the country, that this is a problem with the inventories that the state and US government are using. If you look across all the 6 cities that I've shown here, the estimates for the loss rate to the atmosphere from just the urban distribution and end use portion of the supply chain is about 1.1 to 2.5%. If you add that to the loss before it gets to the city, so from the production and transport of the fuel, which is estimated at 2.2%, you get a total loss rate that's ranging from 3 to almost 5% of the gas consumed. And this is important because, natural gas is touted as, something with lower emissions than coal or oil, because when you burn the methane into CO2, it is more efficient than coal or oil. However, because methane is about 40 times more potent per molecule than CO2, every bit of methane that escapes unburnt is cutting into that greenhouse benefit. So if you have a loss rate between 3 and 6%, the greenhouse impact of natural gas actually becomes equivalent to that of coal. So a lot of the assessments that governments are using to, assuming that there's greenhouse benefits to using natural gas, those benefits are really undercut by these leaks. And so based on these top-down studies, distribution and end use accounts for 20 to 36% of all losses from the natural gas supply chain. So that's pretty significant. So where is this missing methane that we see in the atmosphere, but isn't getting found in these inventories? So this is a paper that came out actually just about a month ago. So it's not included in any of those inventories yet, which measured emissions from stoves in people's houses. So what was interesting is that they measured the stoves all day, even when they were off. And what they found was that 85% of emissions came from the stove while it was off. So this is just coming from tiny leaks within pipes within the stove. Now, other studies had looked at stoves before, but they'd pretty much only focused on when the stoves were on. And so they captured this portion of the emissions, but not this off portion of the emissions. So this is one place that could account for some of those missing emissions. And it definitely needs more study, but we are starting to get more and more evidence that appliances in your home could be a major contributor, which kind of provides some evidence that maybe we should be moving away from our gas appliances towards electric or induction stoves. So I think we're showing that, it's really important to reduce our natural gas emissions. There's a couple of co-benefits to natural gas use, to reducing natural gas use. In addition to reducing greenhouse emissions, it reduces air pollution, which I think you're hearing about from some of the other talks today. Houses with gas stoves have shown higher pollution, higher asthma rates. And then, of course, there's the explosion risk of natural gas pipelines. We're all aware of the Merrimack Valley explosion a couple of years ago. So as we start thinking about ways to reduce emissions, we can switch to electric appliances, and switching to our heat to electric and ground source heat pumps is going to be important as well. Now, it's not going to be possible to immediately switch off all natural gas. This is clearly going to take some time in this process. So in the meantime, I would encourage policy to be aimed at fixing leaks quickly, but not replacing old pipes, because there's just a huge sunk cost, and it tends to promote continued use of natural gas if you put a lot of money into that system. And finally, we tend to see most emissions are coming from a small number of appliances, pipes, or facilities that have significantly higher leaks. So it's important to find ways to identify those leaks and repair them quickly. I just wanted to highlight a couple of things that are going on in Massachusetts that are moving in the right direction, but there's right now on the floor of the State House, so this bill is still in debate, it's called the Future of Heat. And this bill would allow gas companies to deliver renewable thermal energy to our homes. So right now, gas companies are only allowed to deliver natural gas. But this would allow them to do other things like ground source geothermal heat pumps. So this is a pretty cool technology that has a lot of promise, where they put pipelines of water around neighborhoods, and you can hook your a heat pump into this water, and it can warm your house in the winter and cool it in the summer. And what's nice is the gas companies already have a lot of equipment and know-how in terms of being able to put pipes in the streets, et cetera. This Future of Heat bill would also mandate that the cost of fossil fuel infrastructure built after the law cannot be recovered from ratepayers past 2050. So right now, all this money that they're putting into replacing pipes, they pass that bill along to the consumers. And that would not let them keep consumers paying for these pipes past 2050. Another important bill that has been enacted recently in Boston is the Energy Reduction Disclosure Ordinance, which is requiring large buildings to significantly reduce their emissions. So, like I said, I think we're starting to realize how important appliance emissions are in terms of methane losses. So it's nice to see that Boston is starting to move towards setting reduction targets for buildings. So I just wanted to summarize a couple of the key points here. We saw from our atmospheric analysis of methane emissions in Boston, we saw no change in emissions from 2012 to 2020. And we calculated emissions that are 6 times higher than the number that the Massachusetts DEP is currently using, and about 3 times higher than kind of our best estimate with more recent studies. And we saw a loss rate of about 2.5% from the Boston area, which, if you add to the production of transport, comes up to 4.7%. So this is a really significant loss rate, and it's really undercutting the greenhouse benefits of natural gas. And these results were consistent across 6 other cities, where all of them showed these top-down emissions were significantly higher than the numbers the governments are using. So yeah, I really want to encourage everyone to try to support legislation that can reduce greenhouse emissions, reduce our methane loss, and reduce our reliance on natural gas. And it will also have the co-benefits of reducing air pollution and explosion risks. So thank you very much for your attention. Thank you for having me.
A huge thank you to Marianne Sargent, who pre-recorded that section because she could not be with us this morning, so will not be taking questions. But I thought I would just summarize a few points that she made, that there are huge problems with our natural gas inventories, and that the Mass DEP has not actually responded to this study. And it would be one way that we could use our voices to ask that they do so. Another point that she made was that we would be better off spending money on clean energy sources rather than perpetuating our dependence on natural gas. Now for our last speaker, I would like to finish with a child voice. So often we don't include these voices. They get left out of these talks. And this child, Damien, is from an East Boston community, and he will tell us how he experiences air pollution. Take it away, Damien.
Sometimes when I go to the park, I smell gas and I cough uncontrollably because the airport's very close to our house. When I smell like gasoline or like smoke, I rush back into the house. When I'm the only one lay in the park asthma and I have to go back home, I feel sad. Asthma affects me because of my breathing. Can't really run around. I need to take a lot of breaths. I get tired out easily because I can't really breathe that well. If I get really sick with asthma, it's if it's really bad, I have to miss school.
Thank you so much to Damien. And also, I would just note that Dr. Landrigan mentioned that when kids miss school due to asthma, that really affects their learning curve, right? And I also would note that Damien said, when I smell gas, how many of us just smell gas when we walk around our neighborhoods? Think about that. We have a lot of work left to do, for sure. So we've seen today that every level of air pollution has mortality risks for us. There's no safe level. And the laws about air pollution aren't really being rigorously enforced in the US, which has significant mortality and economic costs to us. Enforcement of the Clean Air Act would have tremendous health benefits across our country, and it's something we can advocate for right now. We've also seen that tackling air pollution in our communities has immediate health benefits, as Dr. Rabin pointed out, with improvement of asthma, heart attack rates, stroke rates within weeks, as we saw at the beginning of the COVID pandemic with the lockdowns. According to my colleagues at the CDC, most people in the US are actually quite worried about climate change, according to the polls, but we don't talk about it. So one of the takeaways from today's panels that I would like people to think about is to talk about it. The squeaky wheel gets the funding. For example, a CDC program for climate and health to support communities was just awarded a $10 million budget, but the military has a $778 billion budget. As Nobel Prize laureate and GBPSR founder, Dr. Bernard Lown, famously said, we need to get our priorities straight. We in the US have great power to change the equation, and we should use it. Because when we don't, we all pay with our health, The irony is that those who create the least pollution pay the most, and the disproportionate burden falls on those who are least able to suffer the consequences. The equity issues here are profound, but we all pay. With heart attack, stroke, asthma, cancer, the health effects directly linked to air pollution and air pollution-driven climate change. For their hard work on pulling together today's outstanding program, I would like to thank my joint committee members from GBPSR and Mass Medical Society Committee on Environmental Occupational Health, to GBPSR Executive Director Anna Baker, to our fantastic videographer Jason Bosch, and a huge thanks to our speakers for their time and dedication to increasing learning and understanding around air pollution, its health effects, and what we can do about them. I'm so grateful to my colleagues across the country who are attending today's symposium, and particularly to those who signed up for CME credit, which is helping GBPSR defray the cost of this event. If members of the general public would like to donate a small amount for the same purpose, we would be so appreciative. This final slide that Jason will put up includes some resources for those who would like to become more engaged on the climate and health front, and we'll post it on our website as well with the webinar recording following the presentation. For those of you who are seeking CME credit, please note you'll receive an email within 7 to 10 business days with an online link to an evaluation and CME certificate form, as well as an opportunity to let us know if there are other topics you would like us to cover in future programs. Thank you again for joining us today.
Okay, so we have